We can always.
Hello, everyone. I just want to make sure that everyone is able to hear the audio and see the presentation through Zoom. So if anyone's able to on Zoom confirm that through the chat, that would be much appreciated. Thank you.
Yeah, that's what I would imagine.
So we have
All right, everyone. It's getting to be a little bit after noon, so we're going to go ahead and get started. Welcome to anyone that's attending virtually. So I have up right now the CME information. So I'm going to give this a minute, and then I'm going to move to the next slide that'll give you the actual code for anyone attending internally or anyone that's virtual as well. So I'll just give you a minute if you have not done the CME credit claiming text message system before. For anyone already on the system, within the Henry Ford system, the code is 56387. So what you've normally done for other conferences, you can do for today as well. And then this is our obligatory Henry Ford Health CME slide that we are sharing as well. Okay, I think we're going to go ahead and get started. So we'll see if I can navigate. That'll be the first test. Okay, so I wanted to welcome everyone to our Interstitial Lung Disease Symposium. My name is Krishna Thavaraja. I'm our program director and a very proud member of this team. So again, welcome. Our agenda is very, very packed today. We are ambitious. And so we will be walking through a number of different areas and really trying to update where things have changed in the last year, 2 years, and even last week with some of the guidelines. This is our grand scheme of what we're trying to accomplish today, what we will be working through. So I'm doing our introduction now. We'll be talking about updates in radiographic evaluation of interstitial lung disease, lung biopsy. We will do a mock MDD, and then we'll talk about IPF, connective tissue disease, hypersensitivity pneumonitis, and this concept of progressing fibrosing interstitial lung disease and the newer term of progressive pulmonary fibrosis. Approach to palliative care, and then walk through our drug monitoring system and some of the pharmaceutical implications. And so we have our learning objectives, which is also, oh, sorry, it's not, am I not advancing it right? Okay, hold on. Thank you. Let's try one more time there. Let me try one other thing. So I'm hitting slideshow, but it's not going anywhere. So I broke it. 3 minutes into the symposium, it's over, guys. Thank you for coming. Yes. This
was the new one.
I think maybe because so I think we have to close out that one.
So you don't need this one anymore?
No, we're set there. Yeah. So we'll make sure to close whichever one we're finishing. Maybe that was the issue. Okay. Okay. And so this is the slide that I just talked about to myself about, but again, a variety of topics we'll be going through today. Our learning objectives are to improve really our ability to recognize radiologic pathologic patterns, the role of sampling and biopsy, specifically in interstitial lung disease, a review again of IPF, connective tissue disease, hypersensitivity pneumonia, progressive fibrosing interstitial lung disease, and palliative and drug monitoring. So our team, myself, Dr. Abu Saif, our newest partner who we're so excited to have join us in a very short period of time, Asif Abdul Hamid, Heather Bacher, our nurse practitioner extraordinaire. That was for Asif, but also for Heather, of course. Amber Martirosov, getting better. It's not perfect, but better. Louise Herrick-Mills, Miles, Elizabeth Cosmer, who really keeps it together for us and made this day possible, and social work in rebuilding that. Our key partners are chest radiology, pathology, rheumatology, are really our core group. We also work very closely with thoracic surgery, IP, lung transplant, our GI motility team, pulmonary hypertension, pulmonary rehab, and palliative care, inpatient and home care settings. And without these teams, this would not be a program, and we're very fortunate to have these working relationships. When we look at our program, just sometimes people ask, well, what do you do and where do you go? And so this is what we do. We spend the majority of our time here at the hospital, but we do have clinics at Taylor in Sterling Heights, and the much anticipated opening of a clinic over at the Columbus Medical Center. And then we do telemedicine return visits at the Saginaw Medical Specialty Center as well. When we look at our program in terms of what it is that we do, we formed in 2009, really with the mission of improving the care of patients living with interstitial lung disease through devoted clinical care, education, and research. Over the years, we've been able to very early on add a multidisciplinary meeting with great investment from the chest radiologists and pathologists. In 2016, we started our pulmonary fellow rotation and enrolled our first patient in IPF therapy trial. And then in September of the following year, we specifically formed an inpatient ILD consult service. In January of 2018, the next year, we were able to add a combined rheumatology interstitial lung disease clinic, really to streamline the care of patients with rheumatologic disease and complex situations. And then in May of 2018, a huge highlight for us, a source of pride, is when we attained our Pulmonary Fibrosis Foundation Care Center designation. And so we're one of 68 centers in the US and have found that to be a wonderful resource in terms of what was available to patients now compared to 5-10 years ago. When you look at what we're seeing and where our experience comes from over the years, if you look at where we are now in 2021, we saw 350 new evaluations. We are targeted to increase that number this year. We have close to 700 established patients. And from the database that Dr. Jennings has created and really maintained and helped us, helped in our growth in this way, looking at our numbers, our patient population is predominantly IPF and autoimmune. This combination of autoimmune other and autoimmune systemic sclerosis are really the majority of what we see, with an increasing number of hypersensitivity on pneumonitis as well. So I can see the pictures here, but I don't see them on the screen. So let me see if I did something there. Okay. And so lovely view of the Detroit skyline and the river. And again, that partnership that's so important to us and our patients with the Pulmonary Fibrosis Foundation. So I want to thank you. We're very excited to share some updates with you. And I will hand it over to our next speaker, Dr. Vamudi from Chest Radiology. So I'm going to try to help you move this way. Make sure to close this.
Oh, you have to close.
I'm going to close the old one.
So once I'm done, I'll close my.
Yeah. Okay. Thank you.
Good afternoon. Thank you all. Thank you, Krishna and Ala, for having me. And my name is Darshan Mumiri. I'm one of the cardiothoracic radiologists. And I'm going to be talking a bit about the approach to imaging of interstitial lung disease. We're radiologists. We like to live in dark rooms, so my slides are dark. Apologies. But part of it is because the contrast is better with the sort of background, and kind of gotten used to using dark backgrounds for my slides. So anyway, I have no relevant disclosures. My objective over the next 15 minutes is to review the technique for HRCTs, approach to reading an HRCT with respect to interstitial lung disease. And there are lots of cases to kind of illustrate some of the concepts I'm going to be talking about. So rule of thumb, we get history. We hope and pray we'll get some history when we see our imaging requests. And, but the vast majority are going to say either dyspnea or concern for restrictive lung disease. So when we see a history that's suggesting of obstructive lung physiology, at least mentally, we're expecting increased lung volumes, air trapping, we may or may not see emphysema and signs, direct and indirect signs of small airways disease. And if we're told about restrictive physiology, then we're looking for smaller lung volumes, fibrotic lung disease. Then mixed patterns are there, and then there are non-pulmonary causes. So HRCT is high resolution computed tomography. I know most of you know what it is, but I'm just going to emphasize it's a non-contrast acquisition. And it consists of a thin section volumetric acquisition. So there's typically no gap between the slices. The reason why that's important is that allows us to generate good coronal and sagittal reformats. So particularly for fibrotic lung disease, sometimes when we're uncertain as to whether we're looking at traction bronchiectasis or honeycombing, so looking at these reformats in coronal and sagittal planes allows us to scroll back and forth and see if these cysts are cysts or whether they're connecting to airways and therefore distraction bronchiectasis. And that can sometimes make a difference in, as you will see in the subsequent slides, in calling something UIP or probable UIP on imaging. So we have the inspiratory acquisition. There's typically no gap. Then expiratory acquisition, here we do it incrementally. So it's a 1 millimeter thick slice, frequently acquired in 1 or 2 centimeter increments. And then the prone imaging is not always done. It's done when we see abnormalities along the lung basis, particularly along the costophrenic rhesus on inspiratory imaging, that we sometimes need to tease out. And so we get the prone imaging to see if it persists or it resolves. I've got imaging examples to show you all of this. And one of the key things is you'll realize when we look at the images is we use an edge enhancement algorithm that causes the interstitium and the parenchyma to really stand out. And I mentioned the prone scan, and we look for adequacy and presence of respiratory motion artifact. If there's a lot of respiratory motion artifact, if we catch it soon enough before before our techs have got the patient off the table, we'll call them and say, hey, this part, there's just too much of respiratory motion artifact. For us to give a proper diagnosis, can you rescan them? So yeah, so looking at history, clinical features, spirometry, and then smoking, occupational, pets, medication history, all this is important. So if you give us any of that in the clinical information, it helps us give a sort of better differential diagnosis. So what are the main imaging findings I'm looking at? So for interstitial lung disease, you'll hear the word reticulation in our reports. So reticulation really refers to interlobular or intralobular septal thickening. Ground glass opacity is, as the name suggests, increase in lung density, but not sufficient to obscure underlying bronchovascular architecture is ground glass opacity. Bronchiectasis is irreversible dilatation of the airways. In the context of ILD, we frequently see traction bronchiectasis, where the airway walls themselves are frequently not thickened, but the parenchyma around the airways are abnormal, causing the airways to dilate. And honeycombing is kind of the end stage of the fibrotic process, and presence or absence of honeycombing helps us in making a diagnosis of usual interstitial pneumonitis on imaging. And then we use expiratory imaging to look for air trapping. The word mosaic attenuation is used on inspiratory imaging. So if you see mosaic attenuation on inspiratory imaging, you ideally should be getting an expiratory acquisition to confirm if it's truly due to a small airway cause leading to air trapping, or if there's a vascular cause for the mosaic attenuation. And by scrolling through the scan and looking at it in a cradiocaudal distribution, there are certain conditions that come to mind, and then we're looking at the spatial distribution and then the temporal course. And prone imaging is when we see certain abnormalities. So I'll go through it with illustrative examples. So this is what a normal HRCT should be looking like. So the imaging on the left is during inspiration, and on the right it's expiration. And you can see that the trachea looks a little different. So on expiratory imaging, there's anterior bowing of the posterior tracheal membrane. And there's also a general increase in lung density, and that is normal. You see there's an antero-posterior gradient with an increase in lung density. That is completely normal. That is not ground glass opacity. That's just normal lung where some amount of air is being exhaled, so the lung density will increase. And then when talking about some of these other points that I mentioned, so a lot of this fine lace-like pattern that you're seeing is what we call reticulation. And then you can see traction bronchiectasis, where you have this irregular kind of appearance of the airway due to abnormal fibrotic tissue in the surrounding lung. Then we're seeing honeycombing. You're seeing it here anteriorly on both sides in the subpleural lung. And then the other point I'd like to mention here is the distribution. So this is a nice example of a sort of spatial heterogeneity where you're seeing areas of abnormal lung adjacent to areas of relatively normal lung. So when they're kind of interspersed next to each other, we use the term sort of the spatial heterogeneity. And then I'm just showing you another example of where the lung involvement is more homogeneous. Here in this case, you've got bilateral ground glass opacity in the lower lobes with traction bronchiectasis and some fine cysts. And here you've seen we've acquired also prone imaging, and the abnormality persists on prone imaging. So anytime you see something at the extreme lung basis along the costophrenic recess, if sometimes we're not sure if it's just dependent atelectasis or if it's very early ground glass opacity, we get prone imaging to see if it persists or not. And I've also found sometimes the prone imaging is helpful when there's very mild or early honeycombing along the costophrenic recess. Getting prone imaging helps me visualize that a lot better. So in this case, it's just an example of homogeneous distribution. And in contradistinction to the previous case, so here you see honeycombing, you see traction bronchiectasis, there's spatial heterogeneity. This is a fairly classic appearance for UIP. In this slide, it's homogeneous, there's more ground glass, there's traction bronchiectasis. Both cases are lower lung predominant disease. I'm thinking that this is more likely to be fibrotic non-specific interstitial pneumonitis. So this is another slide just illustrating this craniocaudal gradient. So in this case, you can see this is the case of non-specific interstitial pneumonitis, lower lung predominant, homogeneous is ground glass. There's sometimes the intralobular septal thickening can look like ground glass when there's a fair amount of it. So this is again an example of non-specific interstitial pneumonitis with a homogeneous distribution, lower lung predominant. Again, when I talk about the craniocaudal distribution, so these are the common conditions I'm thinking of it when I see an imaging appearance where the fibrotic pattern or the abnormality is predominantly in the lower lungs. So UIP and NSIP are the commonest conditions I'm thinking of. Even statistically, they're the most common things you'll see. For DIP and LIP, so desquamative interstitial pneumonitis and lymphocytic interstitial pneumonitis, obviously, there are certain imaging features and the history should help. More an upper and mid lung predominant abnormalities. Typically, I'm thinking of end-stage sarcoid chronic sarcoidosis, fibrotic hypersensitivity pneumonitis, and I put Langerhans cell histiocytosis and eosinophilic pneumonia and smaller font size because they're just not as common as the other conditions. So in this case, you can see this clearly a very upper lung predominant distribution of the abnormality. There's clearly traction bronchiectasis, there's honeycombing. And if you look carefully, you can even see there's a cavity in the left upper lobe. And then there are multiple calcified lymph nodes. So this is an example of chronic fibrotic sarcoidosis, resulting in a UIP pattern with an upper lung predominance. So once we've looked at the interstitial features, we also look at the expiratory imaging. So you can see on this inspiratory acquisition, there's clearly mosaic pattern of attenuation, which refers to this alternating areas of increase and decreased density. And on the expiratory imaging, which is the adjacent slide, you can see that I've marked out that sort of frond-like yellow marker on the left lung, on the right lung, really refers to normal lung. And all that area of low density is abnormal lung with air trapping. The left lung, surprisingly, is not as significantly involved. So this is more of a unilateral problem. So it's probably more like a Swire-James syndrome. So the other small airways feature, so we're looking on expiratory imaging, we're looking for air trapping. We look for small airways features. So it can be just a fine centrilobular ground glass nodule. So in this case, we're seeing on the inspiratory acquisition, there are lots of fine centrilobular ground glass nodules seen on the left image. And on the right image, the abnormality persists with some lobular air trapping, particularly in the lower lobes, that's becoming a little more conspicuous. So this is something that we would, when I see something like this, the first thing that's coming to mind is this a sort of non-fibrotic hypersensitivity pneumonitis? And then just to emphasize the importance of prone imaging, you see subtle abnormalities along the postophrenic recess. You're thinking if this is real or is this atelectasis. And in this patient on the left, on the image on the left, you can also see the dilated patulous esophagus. So you're thinking, could this be CT-ILD, likely due to scleroderma? And the abnormality persists on prone imaging in the basal right lower lobe. So and given the fact that there's ground glass opacity, there's no honeycombing, it's fairly homogeneous, I'm thinking that this is likely to be non-specific interstitial pneumonitis in the setting of scleroderma. So there have been multiple iterations of the ATS guidelines on the approach to diagnosis of interstitial lung disease. This was the initial set of guidelines that came out in 2002, and there have been multiple iterations. So this is the most recent guidelines that came out in 2018, and I was also made aware of the ones that came out. There was an update that came out last week. And so thanks to Allah sent me a copy of that. I had looked at it. So I'm going to spend time talking about the guidelines that came out in 2018, and then I'll mention the sort of changes that came out in the update from last week towards the end of my presentation. So HRCT, statistically, UIPs or IPF UIP is the most common abnormality you're going to see. And it's important to be able to distinguish UIP on CT, because a confident diagnosis of UIP on CT, there's a 90% probability that patient will pathologically also have UIP and therefore obviate the need for biopsy. And probable UIP is when, let me show you an image and then it's easier. So this is UIP. So again, in UIP, you can see this heterogeneous peripheral subpleural lower lung distribution. There's traction bronchiectasis, there's reticulation, there's honeycombing. You're seeing all of the abnormalities. So I don't have, I'm looking for my, okay. There it is, okay. Yeah, so, okay, I have to make sure I don't, oh, that's interesting. So I only see it there, I don't see it here. This is, okay. Got it. Yeah. So you can see the sort of heterogeneous pattern of distribution in the subpleural lung, it's lower lung predominant, there's honeycombing, there's traction bronchiectasis. So then you're thinking this is UIP. And this is definite UIP. There's no ambiguity in this diagnosis. In these cases, the patient does not need a biopsy. In probable UIP, you see all of these findings excepting the honeycombing. So if you see traction bronchiectasis in the lower lung predominant, heterogeneously distributed, I'm thinking this is probable UIP as long as I don't see honeycombing. And you can see a little bit of ground glass opacity with probable UIP. And again, in a confident radiologic diagnosis of probable UIP, there's an 80% chance that that patient will, on histopathology, end up having 80 to 85% as per the new guidelines from last week. So typically with UIP and probable UIP, there's no need for a biopsy. And then indeterminate for UIP is where the imaging findings are not really compatible with UIP. So I've got, so this is basically just a slide summarizing a lot of the features that I spoke about. In the interest of time, I'm going to move on. So probable UIP, similar to UIP, but no honeycombing. And then indeterminate for UIP is when you have very subtle abnormalities in the peripheral lungs, you can just see a little reticulation. There's a little bit of ground glass opacity, and you may see minimal traction bronchiectasis, but there's no honeycombing. So in these patients, we have to consider if a lung biopsy is necessary or not, and that's where the importance of the multidisciplinary team meeting comes into play. Now, keep in mind, UIP can be seen in other entities besides IPF. IPF is when you don't have a definite cause, because we see it commonly in connective tissue disease-related ILD. It has been described, like I showed you that example, in sarcoidosis, in fibrotic hypersensitivity pneumonitis. And then asbestosis, again, is not as common here. Again, you need to have the occupational exposure. And you can have an atypical pattern and up to even 30 to 60, so 30 to 60% of the cases with a biopsy proven UIP. Now keep in mind that the presence of traction bronchiectasis and honeycombing on HRCT are predictive of both survival and mortality in patients with IPF. So the radiology and imaging becomes very important in diagnosis and in deciding in treatment. So we've talked a bit about non-specific interstitial pneumonitis at the risk of being a little repetitive. Lower lung predominant, homogeneous distribution, ground glass opacity with traction bronchiectasis, but no honeycombing. You'll hear us talk about subpleural sparing. It's an uncommon finding. We see it in only maybe 20% of the cases, but when we see it, it's fairly specific for non-specific interstitial pneumonitis. When we see an NSIP pattern, we're frequently thinking connective tissue disease related ILD. It's uncommon to see it in idiopathic cases, and other causes are hypersensitivity pneumonitis and drug toxicity. This is another example of NSIP. You can see the lower lung predominant. And I just put this case up because it shows the subpleural sparing pretty nicely there. You see it in the immediate subpleural lung. And there's ground glass opacity, a little bit of traction bronchiectasis, and the abnormalities actually resolve post-treatment. So I just thought I'll talk a little bit about CTD-ILD. And there have been a couple of papers that have talked about some of the more classic signs that you can see with CTD-ILD, particularly UIP with secondary to CTD-ILD. The incidence of ILD is approximately 50% in CTD and can frequently predate the diagnosis. Common findings are NSIP is probably the most common radiologic pattern you're likely to see with CTD-ILD, and then comes UIP. So some of the findings are when we have UIP and we see what's called the anterior upper lobe sign, which refers to, like on this image here, you see this involvement of the anterior upper lobes. You can see the honeycombing on both this axial and coronal image. Then we talk about exuberant honeycombing and straight edge sign, when, as in this image on the right, when the degree of honeycombing is 70% or more of the fibrotic lung. Then you think of connective tissue disease. Again, obviously, if I see this in an older male who smoked, I may be a little less confident with my diagnosis because it could still just be IPF. And then straight edge sign is when on a coronal or sagittal image, you look at the interstitial abnormality, it almost like it stops in a straight line. The reason why this is important is in UIP, the interstitial abnormality has a tendency to kind of creep up on the sides. And with connective tissue disease, is not always the case. Now, these three signs that I mentioned are not very sensitive for CTD-ILD, but they're very specific. And the specificity has been around 90 to 95%. So when you see them, it's fairly specific for CTD-ILD. Now, coming on to the sort of guidelines for the diagnosis and imaging of hypersensitivity pneumonitis. So we used to talk about acute, subacute, chronic hypersensitivity pneumonitis before. And I think it's a little confusing and it's open to a lot of subjectivity and interpretation. So now the diagnosis is, the terminology is not just pick up non-fibrotic and fibrotic. And I think this is better because there's less confusion. And the presence of radiographic and histopathological fibrosis is the primary determinant of prognosis, with imaging features being differentiated between typical and compatible. So the main things to keep in mind is non-fibrotic HP is when you have a CT where you don't have features of fibrosis. So you should ideally not be seeing reticulation. You should not be seeing traction bronchiectasis. You should not be seeing honeycombing or any architectural distortion. So the main finding is going to be predominantly ground glass abnormalities, central lobular ground glass nodule, mosaic attenuation, and then you see air trapping. So you're looking for parenchymal infiltration. You're looking for a combination of parenchymal infiltration and small airways disease. So parenchymal infiltration is ground glass opacity, is mosaic attenuation, and small airways disease is when you have the nodules and air trapping. And the distribution can be craniocaudal or diffuse. And in an axial plane, again, it's more diffuse. So when we see this, we'll use the term that this is typical non-fibrotic hypersensitivity pneumonitis. So just to give you an example, so this was a case that I got from a couple of years ago. This was somebody who ran a bird rescue center and had 25 birds at home. So you can see lots of centrilobular ground glass nodules. And there is a little bit of mosaic attenuation that's visible on this particular CT. I do not have the expiratory imaging, but with that kind of a history and this kind of an imaging pattern, this would be a good fit for sort of typical non-fibrotic HP. I remember this particular case very well because I think she was told by a pulmonologist that she had to give up the birds, and she was then lost to follow-up after that. And then we use the term typical and compatible for both fibrotic and non-fibrotic HP. And compatible is when the patterns are more non-specific. Again, you want a combination of parenchymal abnormalities and small airways disease. You want to see some combination of ground glass nodules and mosaic attenuation and air trapping without any fibrotic changes. Now, when you see fibrotic changes, so this is another example for typical non-fibrotic HP, where on the inspiratory acquisition, we're seeing the ground glass opacity and the mosaic pattern of attenuation. And on the expiratory acquisition, I know it's expiratory because I'm looking at the bronchi. You can see that posterior tracheal membrane and the bronchial membrane is powered. And there's much more accentuation of the changes in density due to air trapping. So this is again in somebody with non-fibrotic hypersensitivity pneumonitis. I do not see any reticulation. There's no traction bronchiectasis. There's no honeycomb. So this is non-fibrotic HP. So fibrotic HP is, you want a combination of parenchymal changes. So you can see ground glass opacity, you can see reticulation, you see traction bronchiectasis, you can see honeycombing with mosaic pattern of attenuation and air trapping. And we used to use the term head cheese sign. When I was training initially in radiology, we don't use the term anymore. We use the term 3 density sign now, which refers to a combination of normal lung, mosaic attenuation, and air trapping. So this is an example for a fibrotic HP, where you can see the honeycombing in the subpleural lung. So this is in the mid lung. You can see the mosaic pattern of attenuation with air trapping. You can see the reticulation. You can see some traction bronchiectasis. So this will be a good fit for fibrotic hypersensitivity pneumonitis. And again, we use the term compatible with HP and not typical HP when the pattern is not typical, and in the sense you can have a UIP pattern with a more basal distribution where you have extensive ground glass opacities with superimposed features of subtle fibrosis. But still, you still want to see mosaic attenuation. You may or may not see centrilobular nodules. You're looking for the 3 density sign and air trapping. So this is one more example for fibrotic hypersensitivity pneumonitis, where you can see the upper lung honeycombing. Clearly, you're seeing the air trapping, and you can see the sort of multiple densities. So you're seeing honeycombing, you're seeing the some normal lung, you're seeing mosaic attenuation, you're seeing air trapping. So this is your 3 density sign. So this is just a quick slide to emphasize why imaging is now important, because it actually helps in driving a big part of the diagnostic pathway. So this is the recent update to the UIP and IPF. The first part of this update talks a lot about how to differentiate UIP from some of the newer findings, the newer disease process we're talking about. So they talk about PPFE, which is pleuropulmonary fibroelastosis. They're talking about how to differentiate UIP from airspace enlargement with fibrosis, UIP from traction bronchiectasis. I did not spend too much time with that because I felt it could get a little confusing. And I thought I would probably just talk about, so this slide basically emphasizes what I talked about in the beginning about how to arrive at a radiological diagnosis of UIP. I just thought I'd talk a little bit about progressive pulmonary fibrosis. So in a patient with ILD of known or unknown etiology other than IPF who has radiological evidence of pulmonary fibrosis, PPF is defined as at least 2 of the following 3 criteria, which is worsening respiratory symptoms, physiologic evidence of disease progression, and radiologic evidence of disease progression. Now, right now, I would say that for the most part, we are qualitatively assessing this disease progression. And it's assessed visually relying on percentage of lung volume containing fibrotic features in upper, mid, and lung zones. So you're going to have the 2 axial images side by side. two coronal images side by side, and then we're comparing and trying to issue a report. An increase in the extent of fibrotic features denotes progression, and what features are we looking for? So this is an example of the last couple of years. So you can see the image on the left is from this year, and the image on the right is from last year. There's definitely an increase in ground glass opacity. There's more reticulation. There's more traction bronchiectasis. So this would qualify. This is in somebody with fibrotic hypersensitivity pneumonitis. So this patient clearly has progressive pulmonary fibrosis. And you can look for multiple features. You're looking for traction bronchiectasis, bronchial epiphysis, ground glass opacity, reticulation. I think, in my opinion, this area is kind of right for use of quantitative imaging, but that still needs to be validated. There are multiple packages available because right now it is a subjective interpretation, and my mild progression or my no progression could be somebody else's minimal progression or vice versa. I'm going to stop there. I hope I've not overrun my time. I probably have, but I'm going to stop there. But thank you.
Good afternoon. Thank you for being with us today. Just before I start, if there is any questions after each talk, we try to design them as 20-30 minutes. So please put them in the chat box, and we have 10 to 15 minutes breaks that we can definitely use to answer these questions. I want to apologize to Joe Montecalvo not to mention your name on this talk, but this is a shared effort between me and Joe. We are so excited to have Joe Montecalvo for the last 3 years now, our chest pathologist, director of the autopsy department, and he will be actually interacting with me on some of the slides. I'm going to talk to you today about the general approach from a pulmonologist for evaluation of ILD using lung biopsies, and we'll go over the evidence for each. We're going to talk about when would a biopsy be indicated or should be considered, when should a biopsy not be considered in the evaluation and management of ILD. And we'll discuss transbronchial biopsies, cryobiopsies, and surgical lung biopsy. And I will also shed some light on the new technology, the genomic classifier using transbronchial biopsies for a detection of UIP. So first of all, when should a biopsy not be considered in the management or in the diagnosis of interstitial lung diseases? And as Dr. Mahmoudi have been through some of the updates, that when we have a patient with the typical demographics, after ruling out other known etiologies for fibrotic lung disease, who has typical or probable UIP, the newest guidelines from a week ago and the ATS guidelines from 2018 suggest doing a multidisciplinary discussion to give the clinical diagnosis of IPF with a high certainty of above 92% to reach the right diagnosis. So in such patients, performing a lung biopsy is not going to change our management. That doesn't stop us from doing the full clinical serologic evaluation and investigate home environment, medications, etc. Another example of when we don't need a lung biopsy, although this paper actually is from 2007, it's actually cited in almost every paper on connective tissue disease related ILD. We may disagree with some of the findings of it, but I'll discuss with you how we look at it. In this study, they describe patients with connective tissue disease related UIP pathology versus connective tissue disease related NSIP pathology and compare them to patients with idiopathic UIP, in other words, IPF. There was a significant, okay, I'm going to give up on the mouse. There was a significant difference in survival between patients who had underlying connective tissue disease and those with idiopathic disease irrelevant to the pathology. Yeah, irrelevant to the pathology that was found. So that paper claimed that 5-year survival for connective tissue disease, UIP or NSIP, was way higher than patients with idiopathic disease. In other words, and of course, the idiopathic NSIP had a better prognosis. In other words, diagnosing a patient with connective tissue disease, it's not going to change your management if you know what's the pathology. So we tend to skip lung biopsy in such patients. Again, I have reservations, so as my team, on the results, mainly because now we discovered that many patients with connective tissue disease can have a phenotype called the progressive pulmonary fibrosis. Dr. Abdul Hamid will shed light on more later today. Third area where a lung biopsy would not be indicated is what Dr. Vamoudi just finished talking about. In patients who have the typical exposure with a typical fibrotic HP radiology, with or without lymphocyte predominant BAL, a lung biopsy most probably will not be needed. It will not change our management, and we can proceed with our management that we'll talk about later on through the talks. Now, when would a biopsy be considered in patients with diffuse parenchymal lung disease, but specifically in fibrotic lung disease patients? If I talk in general about diffuse parenchymal lung disease, then finding a treatable diagnosis is a high priority. And one example of that is vasculitis involvement of the lung. So this is where a surgical lung biopsy would help. Excluding neoplastic and infectious etiology is also helpful, whether that needs to be done through a BL or sometimes transbronchial biopsy or a wedge biopsy for a nodule. But in the workup of a fibrotic lung disease, these become very important. Diagnosis of a treatable cause of interstitial lung disease compared to giving a patient a diagnosis of IPF is also important. If I find organizing pneumonia or non-specific interstitial pneumonia compared to a UIP, patient's prognosis is expected to be better. And these are the patients that, as Dr. Vamoudi shed light on the radiologic patterns, these are the patients that we can decide on when to biopsy and when not. And rarely, I just mentioned this example, rarely that you have a normal X-ray with unexplained hypoxia, pulmonary vaso-occlusive disease is an autopsy diagnosis, and rarely we can use a surgical lung biopsy to confirm a diagnosis if, of course, safe and indicated. The contraindications, as everybody knows, is that if you have an end-stage lung disease, you're discouraged from doing a lung biopsy from an area of honeycombing or from an area of end-stage lung disease. If patients have extensive emphysema or pleural disease, the risk of complications is very high. Patients need to be evaluated prior to surgical lung biopsy for the presence of chronic hypoxia or poor lung reserve, in addition to other risk factors I mentioned here. I shed light on ILD exacerbation, where it is discouraged to perform a lung biopsy at the time of an ILD exacerbation, mainly because of the risk of serious complications, especially, but not excluding others, but especially for persistent air leak. And you may have encountered that through our care in the hospital. Shedding light on BL and transbronchial biopsies in the management of ILD, I'll focus more on transbronchial biopsies, mainly using the transbronchial biopsy in the bronchoscopy suite is for centrolobular diffuse disease process or diffuse parenchymal lung disease more than the workup of fibrotic lung disease. As you know, the limitations for transbronchial biopsies are mainly the size of the biopsy, between 1 to 6 millimeters in the best cases, the crush artifact of the forceps, diseases where it's a patchy involvement of the lung, you may easily miss the diagnosis. And the most important thing about transbronchial biopsies is the inability to have or establish the disease's relation to the pleura, which is one of the main important things in establishing a diagnosis of a UIP, for example. The number of transbronchial biopsies in the pulmonary literature is between 5 and 6 biopsies, and that increases your yield of reaching a right diagnosis in more than 85%. That is a little different in the transplant world, as you guys all have experience in the endoscopy suite. And here I actually have a process where we are able to reach the diagnosis through transbronchial biopsies in a centrilobular process. Dr. Montecalvo.
So this is a nice example of a non-necrotizing granuloma. We have multinucleated giant cells here. It's forming a nodule, presumably in the center of a lobule. It's hard to tell in a biopsy. You don't see the entire lung. And I just have to pour CT scans over there. Lobular nodules. So non-necrotizing granulomas can mean many things: hypersensitivity pneumonitis, sarcoidosis, infection, possibly vasculitis, aspiration pneumonia. So we do stains, GMS, and AFB for lab infection, and you want to correlate with all the clinical things and talk to the team to decide, what might have caused the granuloma.
Thank you. Thank you. Bronchoalveolar lavage, I'm not going to go into details, mainly because of the lack of validated evidence for the bronchoalveolar lavage in diagnosing interstitial lung diseases, but we definitely used BAL to rule out infectious etiology at the initiation of treatment for patients while on treatment, mostly when we use steroids and immunosuppression in many of our patients. In general, lymphocyte predominance is compatible with granulomatous disease, but also is seen in patients with connective tissue disease. But I try to avoid giving numbers due to the lack of standardized evidence for what's percentage is compatible with this disease in general. Now, lung biopsy and the management of fibrotic lung disease. So if we maybe finish talking about diffuse parenchymal lung disease, in fibrotic lung disease, the main 3 or 4 questions in mind are: is this fibrotic lung disease IPF? Is it a diagnosis other than IPF, where hopefully the treatment and the prognosis will be different? And what is the safest modality, at the same time effective with a high sensitivity to reach a diagnosis? In the latest guidelines from 2018, before we come to what came in, there was a comment on surgical lung biopsy, transbronchial biopsies, and cryobiopsy. And in these guidelines, of course, when patients have the typical demographics with typical UIP radiologic pattern, patients were encouraged, or ILD physicians were encouraged not to pursue biopsy due to the known evidence of high probability of diagnosing IPF. Now, for cryobiopsy in 2018, there was no mention in the guidelines for whether or not to pursue that as an alternative to surgical lung. In patients who had, in the 2011, guidelines, surgical lung biopsy was still at that time the gold standard for establishing a diagnosis. And as you see here, for patients who have an HRCT of probable or intermediate UIP, the recommendation was still to perform a biopsy. In the guidelines from 2022 that just came recently, in the guidelines from 2018, the surgical lung biopsy recommendations was dependent on meta-analysis of 26 studies. In these studies, there was adequate sampling in 100% of the patients, and a specific diagnosis was reached in a very high percentage, up to 88%. Third of the patients were IPF. And take in mind that in these studies, majority of the patients did not have the typical radiologic UIP. The mortality rate related to the surgical lung biopsy was, I think, acceptable. So 1.7% procedure related and 3.5% in general. And the rate of complications is listed as you can see it. More literature comes for how to increase the yield of reaching the right diagnosis using the surgical lung biopsy. And here I'm just gonna shed light on what the open lung protocol for all of us, especially if you perform lung biopsies outside maybe the Henry Ford or another tertiary center. The open lung protocol is a standardized way of performing lung biopsy from 3 lobes on one side, of course, and a proper and specific way of how to handle the samples by the pathology department. Dr. Monticalvo shared with me the Henry Ford policy. It's a long paper of how to exactly handle the sample and who can enter the frozen section room and when. So it's very important how to inflate that sample, process it, and deliver it in a good shape to the pathologist to reach the right diagnosis. The biopsies should be a specific size, so 2 centimeters in depth, and generally, as I said, inflated post-resection. And at least 2 lobes should be biopsied. And on the right, we can add a third. And then the presence of multidisciplinary meeting discussion is essential in reaching the right diagnosis, not only with the surgical lung, but in all the others. Now, in 2022, the cryobiopsy came into the guidelines, and I'll explain a little bit briefly about it and about the literature behind using the cryobiopsy. So as we all know, the cryobiopsy is a procedure that's done through bronchoscopy using nitric oxide as a cooling probe in the OR, mainly because patients will need multiple intubations, and each time you take a biopsy, you have to extubate the patient with the bronchoscopy to handle the sample. So patients have to be in generalized anesthesia, intubated. The samples are an average of 50 millimeters compared to the 1 to 3 millimeters seen in transbronchial biopsies. What was documented in the literature about the complication rate of cryo was really a wide range of heterogeneity, and the reasons is this really mainly related to the experience of the center, and of course most of these were case series. So was it the center experience, was it the population that the cryobiopsy was used on, or was there anything else involved? But pneumothorax between 0 and 30% and bleeding between 0 and 78%, or was this and this just added to our suspicion of the absence of standardized protocol on performing and handling cryobiopsies. The diagnostic yield for these biopsies, of course, is better than transbronchial biopsies, and that is validated in the literature. But compared to surgical lung biopsy is what really was a lot of discussion in the latest ATS guidelines about. So I will skip many of the studies that were done on cryobiopsy to talk specifically about the cool dice study. And this is the only randomized clinical trial that was done in 9 hospitals in Australia. So a total of 65 patients. All the patients had surgical lung biopsy plus a cryobiopsy from the same area. And the primary endpoint was to see an agreement after a multidisciplinary meeting on the diagnosis using the two types of samples. So a minimum of 4 specimens were done from separate 2 lobes. The size of the cryoprobe was similar to what was there in the guidelines from 2018, 1.9 millimeter probe, and the freezing time was way less than what was reported in the guidelines from 2018. So a freezing time of 4.6 seconds compared to 7 seconds. And the mean sample, the mean tissue sample was 7 millimeters compared to 5 from the previous guidelines. You can see in this slide the agreement between surgical lung and cryobiopsy purely by 3 pathologists who reviewed all samples compared to the agreement after doing the multidisciplinary meeting with the clinicians and the radiologists. And the agreement was 70% and increased to almost 79% using multidisciplinary meeting. And I actually put some arrows here to where typical pathologic UIP was the most discordance between the 2. But when you do the multidisciplinary meeting, the concordance on reaching IPF diagnosis was very similar between the 2 studies. But then a total of almost 76.9% agreement on diagnosis after multidisciplinary meeting. With that in mind, so I should have put this slide first. The guidelines from 2022 evaluated 40 studies, majority were case series, and maybe the cool dice was the only randomized trial. a total of almost 700 patients. The average biopsy size was 1.9 to 2.4 centimeters, and the number and location of the samples were evaluated and found to be really widely variable between the studies. And the diagnostic yield in average was up to reaching the right diagnosis was in 79% of the cases. The rate of complications, as you see here, pneumothorax and bleeding in 9 and 30%. And the guidelines came depending on these results with the determination that if patients have indeterminate type of UIP on indeterminate type of ILD on radiology, and patients are in an experienced center who can handle and interpret transbronchial cryobiopsies, they gave a very low quality evidence, but recommendation to substitute surgical lung biopsy with a cryobiopsy. And if I go back in the guidelines right now from 2022, so while the transbronchial cryobiopsy was not even there when evaluating typical and probable UIP, now we see that it's in the guidelines considered prior to going into surgical lung. Is that what we're gonna practice in the hospital here at Henry Ford? I will tell you that our experience with the cryobiopsy is something that we're going to have to discuss with our interventional pulmonary team. We definitely need to increase our comfort in performing the procedure and see a better rate of complications. We do have our chest pathology that we will work with on that, but it's encouraging to know that in the guidelines, so maybe we can expose less patients to surgical lung. But as of now, I'm still using the surgical lung when indicated. But definitely we should keep that in mind, especially that it just came in. The last thing I want to talk about, am I good on time, Dr. Donnell? Not really. Okay. The last one is
I never lied to you.
is using artificial intelligence with the genomic classifier to detect UIP signaling in transbronchial biopsy. So the genomic classifier have been in the literature for quite some time, was used initially on surgical lung biopsies and started with the literature of lung cancer. This was extrapolated into machine learning to detect the RNA sequencing in surgical lung biopsies to detect UIP. And that was also experienced recently on transbronchial biopsies. In the guidelines, they mentioned the 4 major studies that studied the genomic classification and see if it can help in aiding the diagnosis and decrease our need for more invasive sampling. The sensitivity of this procedure was 68% in these 4 studies with a specificity of 92. So the panel made no recommendation for the genomic classification to be used for the management, for the diagnosis of ILD, with all the reasons that you can see in this slide. And I want to just emphasize on number 5, because finding a UIP on a biopsy would not stop you from performing all your further workup on these patients. So all the reasons here are maybe the main things why we don't routinely expose patients to the transbronchial biopsy with genomic classification. And hopefully more evidence and more studies in the future will show better sensitivity for such a test, so it may be utilized. At the end, I just want to remind you of what we talked about. This is one way of approaching fibrotic interstitial lung diseases from a Canadian paper. It's not very far from how we practice, at least here at Henry Ford, and I think it's a reasonable approach. And with that, I'm going to thank you all. Yeah. All the way to the right and we'll advise.
You have to close the So yours was which one?
Yeah. Yeah.
Do you want me just to read the cases?
Yeah. Yeah.
All right, so we're gonna do two multidisciplinary cases, examples. So case one is a 54-year-old gentleman who's referred to the ILD clinic for evaluation of interstitial lung disease. He endorsed worsening exertional dyspnea for 3 years and had a high-resolution CAT scan suggestive of pulmonary fibrosis. And he had been seen by pulmonologists with progression of his symptoms within the last year, and now has required oxygen for about 2 years. He does carry a history of hypertension, hyperlipidemia, and reflux disease. And he was told in the past that he was HLA-B27 positive when he was being worked up for back pain related to sacroiliitis. He's on a proton pump inhibitor, ACE inhibitor, and statin, no allergies, and there's no relevant family history. And so we pulled in an example of actually our database. Again, thank you to Dr. Jennings for creating this, of how we kind of keep ourselves on point in our multidisciplinary meetings, because we'll sometimes have 10 patients to get through in an hour. And this is a really nice summary of what the exposures are and the relevant history. And so the additional information here is that this gentleman is a former smoker. His occupational exposure is non-contributory as an engineer, no known exposures. And he does have an autoimmune review of systems, dysphagia, reflux, dry eyes, and has a positive SSA antibody and this positive HLA-B27 antibody that's positive. In terms of PFTs, we can see that he has a restrictive defect suggested here with significant impairment in diffusion capacity. And so Dr. Boomudi will have you review the imaging for us. So I don't see the imaging there. Should we pull it from your
Yeah,
other
I
slides?
can pull
It's
it.
still on the other
Yeah,
one?
it's still there.
Okay, so we will adapt. Okay.
Yeah, just go to that. Just go.
Okay.
So this is the companion CT for the case that was just being shown by Krishna, and it shows that the patient has a fairly homogeneously distributed interstitial abnormality. There's ground glass opacity. There is intralobular septal thickening. There's traction bronchiectasis. It's clearly lower lung predominant. There's no honeycombing. Radiologically, this would be reported as a fibrotic non-specific interstitial pneumonitis.
And so at this point, we'd also ask if there's anything else in your differential,
So-
radiographic differential.
So on the assumption that, sometimes we are given the history, if we're not given the history, we would have said fibrotic non-specific interstitial pneumonitis, and consideration should be made for connective tissue disease related interstitial lung disease. The only other thing is sometimes a probable UIP can look similarly. I did not see any honeycombing, so I would not say typical UIP on the diagnosis I would use.
This gentleman had actually underwent surgical lung biopsy prior to seeing us, and we were a second opinion. So we do have pathology to review. Oh, thank you so much. Okay, better. Thank you, Dr. Casal. Okay. So I'll let Dr. Montecalvo describe this.
Okay,
and I'll
so
try to arrow
we have
show here.
wedges from, I think, what, three lobes?
Yes, right upper, middle, and lower.
Okay, so given the CT findings, we're expecting there to be more fibrosis in the lower lobe. So you always want to actually compare the quantity of the findings between lobes. So this is from the lower lobe, and there's quite a bit of fibrosis in the bottom right-hand side that's obscuring the underlying lung architecture. And then you have some relatively spared lung here. In other words, the alveolar septa are not really expanded like these are by chronic inflammation and fibrosis. And then we have more fibrotic lung at the top. So this is not a homogeneous lesion, so it's not an NSIP. Next slide. Just also a closer shot of the alveolar septa and showing that like some of them are pretty thick and then a little bit and then they're, less thick. So there's a gradation of the amount of inflammation going on here. And this is a cellular and fibrosing process, which means it's fibrotic and has chronic inflammation. Next. And so these lesions are seen on the interface between the fibrotic areas and the relatively spared lung. So it looks like organizing pneumonia, but this is probably focus, which is a term for UIP. It's on all the board exams. So what it is loose myxoid connective tissue that doesn't quite come out into the alveolar space, but sort of abuts into it and expands the alveolar walls. It looks like there's kind of like two, or it's one big one. So, okay, those are the same two. Yeah.
Okay. So in summary, it sounds like what you're telling me is that you're seeing subpleural fibrosis. There's a mix of fibrosis and inflammation that you've identified fibroblastic foci as well. And so in terms of what your impression would be overall of this for the pathologic diagnosis.
So it's a UIP pattern.
UIP pattern, and then there's the amount of inflammation atypical for idiopathic pulmonary fibrosis, or would this still be consistent?
So I didn't get a chance to reveal all the slides, but based on what we see, you can see in the first bigger image, there's a few lymphoid aggregates in the lower part. So if there's more chronic inflammation than you expect for an IPF, this would be more suggestive of like intelligent vascular disease.
Okay, and so when we discussed him in conference, our concern was that yes, he may have an autoimmune condition with his positive autoantibodies, and with the findings on pathology, with the atypical amount of inflammation, he was evaluated by rheumatology. He was evaluated by rheumatology and actually given a diagnosis of Sjogren's. Yeah. Thank you. Okay. And so referred to rheumatology for further evaluation. He was actually treated because of the degree of inflammation with azathioprine and later rituximab, and did have stability in his ILD, although that was a UIP pattern with inflammation for 18 months before suffering an exacerbation. And so this is we love this case that it highlights, geez, just having a biopsy alone is not enough, having that history, because this gentleman was given a diagnosis of IPF before he came to see us. So I think it highlights nicely where we may have a role in terms of changing diagnosis based on history and serology, but with some supportive pathology as well. Our next case is a 70-year-old lady with a history of hypertension, type 2 diabetes, who was admitted to our West Bloomfield Hospital with acute hypoxemic respiratory failure. And so she had reported increasing exertional dyspnea for 1 year prior, and really had been very active up until 2 months prior to admission. Never smoker. She was a former paint tester at an auto company. She retired many years ago, and she had lived in a home with basement flooding, but had moved out of that home about 2 years prior to presentation. She would visit her son who lives in the house, but didn't spend a considerable amount of time there. So in terms of her review of systems, it was notable for reflux, shoulder pain. She did have some autoimmune serology with an elevated rheumatoid factor, but negative CCP, ANA, ANCA, and SCL70. And so I'm going to pull up the imaging again here. Let's see. Okay.
So, it's not.
So I think you have to hit, sorry.
Yeah, so the CT on the right is a CT from 2016, from April 2016, and CT on the left from 2017. And she actually had a chest CT for some other reason in 2012, which was completely normal. I didn't put that up here. So in 2016, what you're noticing is that she clearly has a mosaic pattern of attenuation, and that refers to this alternating areas of increased and decreased density. There's mild traction bronchiectasis, as you can see here in the anterior right upper lobe. and there's some reticulation. So just looking at the 2016 study, I would definitely be concerned, particularly with the history of, given the fact that she'd been exposed to paint fumes and the basement flooding. You know, she's got fibrotic features, she's got small airways features suggestive of, you know, some air trapping. I would definitely be concerned about a fibrotic hypersensitivity pneumonitis. And then the subsequent study that was acquired less than a year later, so February 2017, there's clear evidence of progression. Now there's definitely honeycombing. There was no honeycombing on the prior CT from 2016. On the CT from 2017, there is there's sort of very bronchovascular honeycombing. There's some honeycombing here in the anterior right upper lobe. And there's just a general overall increase in the degree of reticulation, the ground glass opacity. So she's clearly got a sort of progressive fibrotic component to what looks like fibrotic hypersensitivity pneumonitis, at least on imaging.
And then anything else in your radiographic differential?
Not many things at this point, given the degree of air trapping that I'm seeing. I would have thought like an atypical UIP can present like this. Air trapping is rarely seen with UIP, so I would still probably put fibrotic hypersensitivity pneumonitis higher up.
She had about a 2-liter oxygen requirement when she was admitted to the hospital. She underwent a surgical lung biopsy prior to discharge. So Dr. Montecalvo. Oh, I keep forgetting. I'm sorry, guys. I'm not doing
Nailed it.
a job there. Okay.
So we have a wedge that looks a lot different than the last one. We don't see the degree of fibrosis. We have well-expanded sacs, and we have nodular lesion here. So this is the bronchovascular bundle airway with its accompanying artery, and then we have this guy right here. So we have the peribronchial process, so airway-centered process. Shot so you can see what these look like. There were numerous nodules, and they were all around the airways. So this looks like the first picture of a slide that we saw in Paula's presentation. This is a non-necrotizing granuloma, and we have multiplication to the granulomas. Do we have another picture of the closer shot of them? Let's go back to the first slide.
This one.
Yeah, I just want to focus on it because it is a different type of granuloma than one we saw before. This is called a loose granuloma, so they're not as cohesive like in sarcoidosis. There's actually going to be chronic inflammation within it. The cells are not going to be back to back, and you'll have like different types of giant cells, so multinucleated, and then pseudocystis with one nuclei, and they're not exactly like circular. They're kind of spilling out a little bit on the border, so poorly formed loose granulomas.
We're having a hard time hearing you online. I don't know.
Oh, yeah, you have to stand here.
Thanks.
Thank you.
Okay, so this picture has about 2 things going on. Oh, you got me. Thank you. So this is a multinucleated giant cell with some macrophages next to it. So this could be called a loose granuloma. It's kind of semantics at this point, but there's 2 loose connective tissue plugs that were reminiscent of the fibroblastic foci we saw in our UIP example. But in this example, these represent organizing pneumonia. So we have granulomas and organizing pneumonia, and they're both centered around the airways. So this could be signed out as a bronchiolocentric cellular interstitial pneumonia with scattered loose granulomas and focal organizing pneumonia, with HP being the top differential.
And so she was given a consensus diagnosis of hypersensitivity pneumonia, was treated because of the active inflammatory component, did receive treatment with systemic steroids at the time. Anti-fibrotics were not approved in non-IPF diagnoses. And so at some point she was also offered a steroid sparing agent, but unfortunately, as Dr. Vamudi highlighted on the film, her disease progressed. She had significant fibrosis and ultimately succumbed to her disease. So those are our two cases. We're going to do two just in the interest of time. So hopefully that gives an example of some of the things that we walk through, that we work through together. And in both of these situations, you could argue that we may have been able to get around biopsy, but of course, whenever we have them, we love to learn from that and improves our diagnostics. I think this is our time to take a short break. We're going to do 5 minutes. 5 minutes, and then Dr. Abousaif is going to field if there's any questions. He's going to double check and talk through those. I'm going to move the microphone back. And then I believe we are talking about IPF. So let's close this. Let me mute. Here, okay. going to go ahead and get started. We're a little bit behind, but for an ILD doctor, this makes us very ahead of schedule. So we're excited to only be this far behind. So I'm going to talk about idiopathic pulmonary fibrosis, and lucky for me, a lot of the things that I was going to talk about actually have been addressed, and that'll get us some time back here. I'm sorry, my screen is just freezing, so just give me a second. I'll get this back. Okay. Disclosures that aren't really relevant to this talk. So just to address epidemiology. So in IPF, this is still really a challenge for us. Part of it is the definitions. Part of it is the reporting in country. So I can't imagine that there are no cases of IPF or this minimal in Asia and Africa. It is really the reporting system. And here you can see there's a range of cases, and this is just looking at incidence, not prevalence, but the disease is certainly increasing in incidence because of our aging population, and in prevalence because of that we now have therapies that sustain patients for longer. When we look at pathogenesis, I have two versions of this. This is the nice and simple model for me, which focuses on what happens after an injury. So what we normally expect to happen is that basement membranes, if I can get this to show up, there we go. So basement membrane is typically preserved. The fibroblasts do not cross that basement membrane, and there's type 1 pneumocyte restoration. In a fibrotic situation, what will happen is that there's disruption of that basement membrane. You have migration of sometimes inflammatory cells, but really fibroblasts is the issue here, and deposition of collagen. The far more advanced notion of pathogenesis also involves epithelial cell injury, epithelial mesenchymal cell transition, myofibroblast activation and transition to fibroblasts, matrix deposition, and cross-linking of collagen. And so these, what I've circled, are the different areas that are also our targets of therapy, but what's so involved in the pathogenesis of idiopathic pulmonary fibrosis. When we look at natural disease, I think we all have a better understanding this over the last several years. That there are patients that progress in this way, but it's not the majority of patients that progress with slow progression and just slowly get worse over time. The other small proportion of patients is this rapidly progressive subset. So within a year of developing symptoms, getting a diagnosis, those patients are passing away. And so those are not, neither of those are the majority of the patients. Most patients have this stepwise decline, where they will describe to you, a patient will describe to you, I was fine, I was stable, I felt okay, there was nothing, I didn't really feel like anything was wrong, and then suddenly feel like they either describe it as falling off a cliff, being blindsided, and oftentimes this is related to an acute exacerbation. And when patients suffer this, we often do not get them back to where they were, and they have a new baseline. And so they've stepped down, and this happens again. And with any of these, there's risk, it's a significant risk of death, but real loss of function for patients during these times. Now this slide is old because now, and hopefully we can have hope as well, that for lung cancer, the mortality is much better with the advent of immunotherapy. But for IPF, without treatment, it is a 30% 5-year survival. Sorry, not mortality, 30% 5-year survival. When you look at what happens to these patients, if you look from just initial visit and onset of symptoms, because you'll have the patients come back to you saying, look, you know, I told them I was coughing, I told them something was wrong, and that was maybe a few years ago, and you're telling me that this is a diagnosis has a 3 to 5 year mortality. I think we can look at some of the difference of what happens from onset of symptoms, which the median survival is 60% at a little bit further out. And then you look at the median survival from initial visit, and that's where that 3 to 5 year comes from. So it's a little bit longer from the onset of symptoms. So we're going to talk about sort of the standard of care of IPF, a little bit of update in therapy trials. We've already reviewed the updates in the diagnostic algorithm, so I am going to move forward. What we do when we have radiology and pathology, is when we'll have, say, someone who goes for biopsy indeterminate or alternative or a pattern that is consistent with an alternative diagnosis. Those patients, if they have probable UIP or UIP on biopsy, those patients are given a diagnosis of IPF and indeterminate. And then when we're seeing features that aren't consistent with UIP, we will give patients a non-IPF diagnosis and look for another cause. As Dr. Abu Saif is going to talk about more in his talk, the presence of an autoantibody when we're talking about workup for these patients doesn't improve the prognosis. So we do encourage a screening, sending antibodies. But again, just having a positive antibody and no disease that goes along with that doesn't improve the mortality of an IPF patient. That mortality is similar to a patient without any positive antibodies. I think the other thing that we're incorporating more in our practice over the last few years is actually trying to prognosticate patients, because it isn't a one size fits all. If we see someone who is much earlier in disease, we know their survival. If we're catching them at that point, we know their survival is much longer. So the GAP score looks at predicting mortality. So gender, age, and physiology, incorporating the FVC and the DLCO. And just to show an example, so if you're seeing a gentleman who is under the age of 60 and has relatively well-preserved FVC and DLCO and is a stage 1 of disease, the 1-year mortality is 5%, 2-year mortality is 11%, and 3-year mortality is 16%. Still worse than the age-matched population, but not as severe as someone who is, say, stage 3, who has more of a 60–70% mortality at the 3-year mark. And so we will use this. It doesn't predict well what happens longitudinally. So if a patient has an acute exacerbation 2 months after you see them, this is, they're no longer going to be a 16% 3-year mortality. When we're evaluating these patients, we like to obtain a 6-minute walk test on evaluation for 2 reasons. One, it gives us a better sense of how functional someone is, but really it's the oxygenation that's key here. So for a patient who on a 6-minute walk test on room air desaturates below 89%, there's much worse survival. So you go from, if you have preserved saturation, 6.8 median survival, your median survival, and that halves as soon as you start needing oxygen based on a 6-minute walk test. So different from what we see in COPD, which is you'll see someone on 2 liters, that patient will be on 2 liters for years and will do well for a long time, potentially a longer time. But for an IPF patient, that is really a critical value and should be a trigger for a lung transplant evaluation. When we're following these patients, what do we follow? So for 6 months, for the patients who have preserved oxygenation, things that help us are DLCO, 15% decline in DLCO is a predictor of worse mortality. Same with 10% decline in FVC, an increase in desaturation on 6-minute walk test, and a walk distance decline. For patients who have hypoxia, a 15% decline in DLCO at 6 months. So our standard of care really should be at least every 6 months. We do it more frequently in the hopes that we're catching changes, but at least every 6 months, these patients warrant walk tests and PFTs. Looking at genetics, because this is the next thing that's coming, right? This is, we're seeing in other disease states, if we can have a little bit better genetic characterization of those patients, does that have treatment implications? And if you have a terminal illness, of course, you want to figure out if your family member may be at higher risk of that. So clustering of pulmonary fibrosis in families was first noted in the 80s. And family history is actually one of the strongest risk factors for IPF when there is a family history of IPF. So simply asking a patient in clinic whether they have a family history of lung disease, pulmonary fibrosis, rheumatologic disease, for us it seems to be helpful in finding that. In our IPF patients, we will look to see if there are CBC abnormalities, there's unexplained cirrhosis, or a family history of pulmonary fibrosis, and that's where we start to consider more seriously genetic testing. There may be implications for therapy in the future. If you look at the data for N-acetylcysteine, for example, in patients who have a MUC5B promoter abnormality, there may be some benefit in those patients. We're not sure, but some of these genetic variants may have implications for treatment. When you look at the proportion of patients, so sporadic are patients who don't have familial, and that's the majority. But this is not a rare, as rare as we probably thought several years ago. The familial could be up to a fifth of patients. When we look at those variants, the ones that are most commonly identified are the Tert mutations, which is not a common variant. It's actually a rare one, but it translates into disease more often, versus common variants that don't necessarily translate into disease. And that's where the MUC5B and Tolliver, and sometimes you can see Tert on both spectrums. So for our family members with family members of IPF, 1 in 6 relatives of a pulmonary fibrosis patient, when this was studied, had interstitial lung abnormalities. The prevalence of these abnormalities weren't really different between familial or sporadic. And the ones that seem to be associated with having undiagnosed interstitial lung abnormalities, so asymptomatic, they found very mild changes that were suggestive of very early interstitial lung disease, were with telomere length and MUC5B promoter. So patients who are at risk and have first degree relatives of familial PF patients, about 15% of them have early disease. And early detection may have treatment implications. If you find these patients earlier, are you going to start them, offer them anti-fibrotics, or is the surveillance going to be different? So who do we send for genetic testing? And it's still a little bit unclear. So sporadic, it's not clear at this time that there's a true benefit for it, because we're not sure if it has treatment implications. But for now, so we have not been sending all of those patients for it. For patients with familial, because of the concern for IPF, personal risk to the children and other family members, and reproductive decisions for some patients, that is now being looked at a little bit more closely, and we're more likely to offer it. Really great resource from the Pulmonary Fibrosis Foundation for patients regarding genetic testing. And they also have sort of ways of actually finding folks that do this, because not all institutions offer this. And so there are now commercial companies that do this. Insurance covers this sometimes, and there is counseling involved with that. Looking at treatment, as we talked about some of the monitoring for disease progression with PFTs, consideration of CAT scan, especially in our patients who have risk of lung cancer as well. And then treatment considerations we're going to go through in just a minute. And then we're always thinking about what else we can do for this patient to help them feel better. So we're trying to identify comorbidities, pulmonary hypertension, reflux, OSA, lung cancer. These are things that have prognostic implications and treatment implications. At any stage of disease, you really can talk about symptom control. It is not palliative care, as Heather is going to go through. It's not just meant for patients at the end of life. And then I think the other thing that we sometimes forget now that we have FDA approved therapies is that patients are candidates for research. Even on anti-fibrotics, most of the research studies now look at that. And then finally, as we talked about, and we'll kind of touch on every so often, is evaluation, or at least consideration of lung transplant. And that's a moving target. I think, I know at our institution that age has changed. The criteria has now been moved up from 70 to 75. So I think just at least thinking about it and revisiting that with patients, because sometimes that does change. Just to touch on pulmonary hypertension, the impact of that, there is a 2-year mortality of a patient who has IPF with pulmonary hypertension of 60%. And so very significant change in disease course for a patient with pulmonary hypertension. So this is something that we screen for routinely. When we look at specific treatments for IPF over the last 30 years, you can see that things have dramatically changed, where we're looking more at immunosuppressants in the beginning, and now looking at targeted as we move up this, I'm sorry, I keep pointing to myself here. As we move up of this towards the upper right-hand corner, looking at more targeted therapy, oftentimes inhibitors of specific molecules. So when we look at what we're targeting, oftentimes it's something related to that epithelial cell injury or the fibroblast response. And then we have other areas that we're looking at with the microbiome and with turnover of some of this deposition of collagen. When we look at what we know for what's FDA approved, nintedanib slows the rate of FVC decline in IPF. We know that pirfenidone lowers the rate of decline in FVC or death in IPF. And this isn't news. This has been available for quite some time. What we know now, looking back at these patients and with larger cohorts of patients, is that there's a mortality benefit of anti-fibrotics, and we've incorporated this into our counseling of patients. So a patient who maybe doesn't feel that bad, doesn't need oxygen, will sometimes say, you know, I just don't know if I want to take these medications. And we encourage at least thinking, you know, seriously about it because of the mortality benefit in these patients, and that still that lack of predictability. So looking at nintedanib versus placebo, over time there was a improved mortality, and same with pirfenidone. So this is something given years back. So this is a graduation. This is a grandchild's birth. This is you know, another family member's event that patients could get to. Looking at pooling the anti-fibrotics, so the mortality benefit, we see if you look at survival, it's improved in patients on anti-fibrotic compared to IPF patients without. And even if a patient has an acute exacerbation, there is still a benefit to being on an anti-fibrotic. So this isn't something that, again, we don't wait for these patients to get worse. When we know that someone has IPF, we're offering it, and if there's a reason they're not taken, we're looking for that reason why that is. In terms of risk of events for all-cause mortality, hospitalization, acute exacerbations, and mortality after acute exacerbation, all of those favor use of anti-fibrotics. When we look at other therapeutic targets, this is actually sadly the simpler of the two. We have a lot of other areas that we're looking at for either fibroblast activation, the epithelial mesenchymal transition, and potentially hypercoagulability. When we look at recent trials, the ones that are standing out a little bit more are looking at altering the microbiome, looking at collagen cross-linking, although this was a negative study, and then more recently monoclonal antibody to IL-13. And trials that we've participated in and maybe have upcoming as well would be, we were a site for nintedanib and PF-ILD and scleroderma-related ILD, a site for monoclonal antibody to connective tissue growth factor, this trial for autotaxin inhibitor, which was stopped for lack of efficacy. We're planning to start be site initiated soon for study looking for pentraxin or permatraxin, and then inhaled Remodulin for IPF, and it cut off, I'm sorry, but inhaled nitric oxide and interstitial lung disease. When we look at some of what these studies offer, oftentimes it is not an improvement in lung function, but a slowing in rate of decline. And so this is looking at that recombinant human pentraxin 2, which targets some of the macrophage activation and some of the turnover of some of the collagen. What we look at in terms of what we agree on, what's helpful in IPF patients: oxygen therapy, pulmonary rehab, vaccinations to prevent infection, lung transplant evaluations, steroids in the management of acute exacerbation, and certainly in patients who have symptomatic or proven reflux treatment. There's no consensus on these other areas. Mechanical ventilation, we actually try to intervene before to prevent these patients from being, if they continue to progress, to go on mechanical ventilation. These are predominantly negative studies. And then in terms of treatment of pulmonary hypertension, we do have an FDA-approved therapy for group 3 pulmonary hypertension. We're not sure of the mortality implications yet. And so there is some benefit there, but again, we don't know of the long term. Moving on to, so that's your day-to-day management, moving on to the acute presentations for patients. So patients who are acutely hypoxic with IPF, I think sometimes we all get into a mode where we think, well, it's just your IPF. Lots of things that can happen and do happen to these patients. So besides the acute exacerbation, we are also thinking about PE, CHF, pneumothorax, and these are all things that we find in our patients. When we're looking, how bad am I on time? Okay. When we're looking at acute exacerbations, what we expect to happen to patients over years' time is that there's an increase in, this is an area of fibrosis, there's an increase in fibrosis over time. That gets accelerated in the setting of an acute exacerbation. So here you're going to see what looks like diffuse alveolar damage. So you should see hyaline membranes, and in really days even and weeks, you see a significant increase in fibrosis. When we're looking at the definition of acute exacerbation, some of this you can use to be reassured about when trying to triage patients. So if a patient has an acute significant respiratory decline, When we talk with these patients, and one of the things we have all of our patients get our pulse oximeters for home monitoring, because if they call us and tell us they're feeling worse, but their oxygenation is the same, is where it has been, that's not, we're reassured that that's not going to be an acute exacerbation. Something is happening. We need to figure that out, but it's not an acute exacerbation. What we should see is that it's either a new diagnosis or prior diagnosis of IPF. They acutely worsen, so that we usually try to stick to this 1 month duration. I will put in a caveat for COVID, which seems to be a delay in exacerbation in the patients we're seeing. It's usually more 4 to 6 weeks. The exacerbation may happen after COVID infection. And then new ground glass opacity, and the deterioration is not related to heart failure. You'll notice that there's nothing about infection here, because we know infection can be a trigger for an IPF exacerbation. We used to think of them as mutually exclusive. They are not. Viral infection absolutely is a trigger for exacerbation. When we look at these imaging, what you should see is the superimposed on the right-hand side there, you'll see superimposed ground glass on that prior fibrotic disease. When you see that, the things you're thinking about are pulmonary edema, ILD progression, and then acute exacerbation. Whether that's idiopathic or secondary is for us to try to figure out, but that would be the 2 types of exacerbations that we can have. Typically viral infection, aspiration, but there's probably some genetic predisposition, and we don't always identify a trigger. And how do we treat these patients? So while we're evaluating for infection, heart failure, and oftentimes they're too hypoxic to perform lavage, while we're waiting on some of this to come back, they're getting antibiotics, diuresis, and we favor doing 0.5 gram up to 1 gram per day of methylprednisolone, and this is not FDA approved, for 3 days with a taper if they're responsive. Now, you heard me talk about diffuse alveolar damage. Why would we bother to give steroids? There's a small subset that have organizing pneumonia as part of their exacerbation, and those are the patients we're hoping to find. And really, I think consideration of palliative care, and then we've been very fortunate in being able to work closely with the lung transplant team for someone who had a good functional status coming in, even if it's first presentation, of looking at them for lung transplant. So moving to lung transplant. So lung transplant and IPF. So actually, diagnosis of IPF is a terminal illness, and the mortality without treatment is worse than the mortality related to lung transplant. So that is an indication for referral. So as soon as someone has a diagnosis, you should be thinking about it. And then other time points to consider would be when that patient desaturates on a 6-minute walk test, and that's I think a key time to bring that up. And then 10% decline in FVC or 15% decline in DLCO. When you look at all comers for transplant, the blue X's are the patients with restrictive lung disease. So that's the majority now of patients undergoing transplant. The next graph, which is the upper right-hand corner, is time on the list and time to wait. And again, the turquoise X's are the restrictive lung disease or fibrotic lung disease patients, and that wait time, because of severity scoring by disease and oftentimes by oxygenation, is much shorter. And then in terms of survival, this is just looking at all patients, and that hasn't changed dramatically. So when we counsel patients, it's still a median survival of 50% at 5 years. And so we still will talk about that in counseling the patients. And so I'm going to move to just our summary. And in terms of IPF, it still carries very high morbidity and mortality. Any oxygen requirement on a 6-minute walk test is associated with increased mortality. Anti-fibrotics slow the rate of progression and improve mortality, even after acute exacerbation, and should be considered in all patients with IPF. Lung transplant evaluation should at least be considered, if not referred. Research trials while taking antifibrotics are definitely an option. And genetic testing is a consideration with any suspicion of family history, and if there's suspicion of telomere-related disease. And so with that, I am all set. And so I believe Dr. Abousaif is next, and he's going to talk to us about connective tissue disease. So I'm going to. Of course.
We are good on time.
Are we? Oh, I caught us up. Okay. I'm surprised.
Yeah.
Yes.
If you have a patient who has IPF and they're undergoing like an elective outpatient surgery, I think we kind of talked about this in my ILD class, but what would be some of the things that you consider for anesthesia? other than
So
that?
that is a really good point. And I put it in the acute exacerbation side and then I took it out. But absolutely, that is an area that we were missing things. So we always counsel that those patients, if they need general anesthesia, that they undergo low tidal volume ventilation. And anesthesia has been really good about that because it's really, it's well supported in the literature. But if we can avoid general anesthesia at all, we prefer to do that. We recently saw someone, I think as an example, who had been stable for several, not stable, but very, very slowly progressing in his IPF for several years on anti-fibrotic, has a shoulder surgery that was not at anything that was complicated. And then within 3 weeks had an exacerbation, was admitted to the hospital. So we do need to counsel. We don't try to prohibit all surgeries, but if something is truly elective, we will try to figure out a way around it. And then we'll also talk about, we'll ask that those cases get done in the hospital if they absolutely need to be done. But we do know that the risk of exacerbation, even if it's not surgical lung biopsy, is quite elevated. It's hard to sort of quantify that though. Yeah, so other things to watch out for. So for both alcohol use, smoking, and liver cirrhosis are contraindications. For nintedanib, if there's a history of uncontrolled CAD, recent strokes within the last 6 months, and then we've also included sort of severe peripheral artery disease. Those are all things that would make it more challenging for nintedanib. If you have a patient who is outdoors all day long, working in the sun, and even with SPF 50, pirfenidone, they're likely to get some type of photosensitive rash. Those would be the big, anything I missed?
And
Yeah.
Amber will
Yes,
cover
and
more
thank you.
in her talk as well. There used to be some complications or even contraindications to nintedanib in particular that Amber will shed some light on our experience with you. Oh, great question. Okay. There is no way I'm going to be able to handle all connective tissue disease related ILDs, but what I will try to do in this talk, I have no disclosures for years to come, hopefully. We'll see. What I will try to do is shed light on the initial workup, what a pulmonologist should think of, what should alarm you for detecting connective tissue disease in your clinic patient with diffuse parenchymal lung disease or fibrotic lung disease. We'll go through specific disease scenarios, and we'll talk about the research term idiopathic pneumonia with autoimmune features, and what does that mean? How does it change our management, if any? As you all know, connective tissue diseases are not anymore lumped into these 5 or 6 categories. Yes, there are the well-known 5-6 categories that meet the classification by the rheumatology societies, but there is a lot of overlap for our patients in clinics. I put you this slide to show which connective tissue diseases have more of pleural disease and pulmonary hypertension like lupus, compared to diseases that have more and higher percentage of developing interstitial lung disease. And here we mainly talk about polymyositis, dermatomyositis, overlap syndromes, and systemic sclerosis. Rheumatoid arthritis has almost like one of all. So rheumatoid can come with ILD, airway disease, pleural involvement, and I'll go through specifics through these diseases as well. We know that connective tissue diseases in the latest evaluations by many centers around the country represent almost 20% of our interstitial lung diseases. But as I said, this classification that you see of 6 categories is just for the diseases that meet the criteria. Many of our patients have the overlap, especially in the ILD clinic, and I'll explain why in a minute. We are able to identify patients with connective tissue disease way more now compared to the past. And this old paper from Johns Hopkins in 2009 is cited by many review articles about connective tissue disease. So in this retrospective analysis, the Johns Hopkins ILD clinic got patients into the clinic. 15% of them were already established with connective tissue disease and came to the ILD clinic. And another 15% had the new diagnosis depending on the workup that was done which made almost 1/3 of their patients in the ILD referral clinic as with a diagnosis of connective tissue disease. They found that the new diagnosis of connective tissue disease was mostly associated with specific serologies and ANA more than 1 to 640, although the pattern is as important as the titer, as you guys know. Elevated CPK and aldolase, indicating the presence of overlap, dermato or polymyositis. Now, of course, in your question, leaving the ILD rotation is, what is the best workup? How much serology should I do? Is this too much? Is this too little? Am I missing anything? Generally, in your HPI, the symptoms and physical exam findings that you may encounter in your clinic that could point you towards connective tissue disease are involvement of other organs. And for example, history of colitis or inflammatory bowel disease, unexplained thrombocytopenia, female, younger age, a response to steroids by the history. And you guys have noticed how much we emphasize attention on, I got worse, I got this short course of steroids and I got better. This is very important in establishing a diagnosis of connective tissue disease. Then in your physical exam findings, the joints, the presence or absence of Raynaud's, focal weakness, numbness, myalgia. In your labs, I will show you, this is actually the serology that at Henry Ford, this is what we do as an initial workup if you don't have any specific suspicion of an underlying autoimmune disease. This is kind of our routine serology. And as I said, in your physical exam, you might have and see the mechanic's hands. You might see Gautron's papules or changes around the nail fold. You might have sclerodactyly. And all these raise your suspicion for an underlying disease. In this paper from Spain, they reviewed patients between 2013 and 14, published it later on in 2020. In this one, actually, they had 15% of their referred patients in that 1 year diagnosed with new connective tissue disease related ILD. The serology, and it was a sample of like 140 patients. The serology that was done in this clinic is way more robust and extensive than the one I just showed you. So they would do the CPK aldolase, the full myocytes panel, ANA, ANCA, SCL70, polymerase 3 RNA. So they would do all of that for the patient, in addition to ANCA, of course. With or without bronchoscopy with BAL, I mentioned previously that the presence of lymphocytes, predominant BAL, is important in this cohort of patients. But I want you to leave this conference with at least ordering the minimal basic workup, but other centers are way more aggressive in their initial workup for patients. There is no way I can tell you that the prognosis of all connective tissue disease-related ILD patients is the same. This slide, which is almost like 14 years ago right now, indicates that the presence of an underlying disease, connective tissue disease in particular, carries way better prognosis compared to the idiopathic forms, or in other words, IPF. But you will see, especially when Dr. Abdulhamid talks about progressive pulmonary fibrosis, how there is a subset of connective tissue disease patients who have a similar prognosis like the idiopathic forms. With that, I'm going to start with 4 categories of diseases. I'm not going to go into through details, but I promise you that I try to involve all the major clinical trials on treatment, the guidelines in management, which is not a lot in this subset of ILD. Systemic sclerosis is the most, it's actually the most connective tissue disease that clinical trials were run on, and I'll show you why. So systemic sclerosis, rare disease, rare to have an initial diagnosis. The prognosis of this disease over the years have significantly changed between the 70s up to the late 2000s with specific reasons. While renal crisis and mortality related to renal disease and cardiovascular disease was predominant in the 70s as a main reason for mortality. You see that in the early 2000s, the mortality now is mainly related to pulmonary hypertension and to interstitial lung disease. Couple of reasons on that are we are not using high-dose steroids on these patients like we used to, which was associated directly with renal crisis. And the presence of vasodilators for the management of PH have also improved survival in these patients. Pulmonary fibrosis being the lead cause for mortality in these patients right now, this is one of the main reasons why a lot of clinical trials on variable medications have been conducted lately. Very common in scleroderma patients to have ILD, up to 78% of the patients. That's why, and that's what's found on autopsy of scleroderma patients. Although, as I said, extremely rare disease. It was found that normal PFTs do not rule out the presence of interstitial lung disease with these patients. That's why an HRCT with prone imaging is the standard of care for a rheumatology clinic to order at the time of new diagnosis of scleroderma, whether or not there are pulmonary symptoms. Sorry. The risk factors for progressive fibrosing ILD in patients with scleroderma are the presence of diffuse compared to limited disease, the African American race, the older age at the time of diagnosis, and the first 5 years of diagnosis, for some reason, is associated with the progressive phenotype of the disease. The presence of the anti-topoisomerase SCL70 is associated with the progressive ILD. And I learned actually recently that if patients have anti-topoisomerase, they will not have, so a rarity of patients will have both with centromere, which is more compatible with the presence of pulmonary hypertension in these patients. Here is a scoring system that was published in England in 2008 that differentiates patients between extensive and limited disease depending on the quantification of fibrosis on the CAT scan. If patients have fibrosis more than 30%, they are automatically into the extensive disease. And an FVC less than 70% is enough to put them into that category as well. And you can see the difference in Kaplan-Meier survivor curve, a difference in survival between the two categories. As I mentioned, and Asif will go more over what's the subset of scleroderma patients who go into progressive fibrosing ILD. The literature is rich in clinical trials with agents to treat scleroderma, and I'll try get you through maybe the recent and the most important that changed our management. We talked about steroids and renal and the risk of scleroderma renal crisis. The cumulative dose that was reported in case series is around 30 milligrams of prednisone. And that's why you see that whenever we put patient with scleroderma on steroids, we are trying as soon as possible to drop below 30. What to monitor for the renal crisis is mainly hypertension. So blood pressure management before the serum creatinine will go up. Cyclophosphamide was used and trialed in what we call the SLS1 double-blinded randomized phase 3 trial, and found to show efficacy in managing and stabilizing patients with scleroderma-related ILD. Later on came the SLS2 trial that put patients on 24 months of mycophenolate mofetil, way less toxic compared to a 12-month of cyclophosphamide with another 12 months of placebo, and found similar efficacy in stabilizing the FVC in these patients, where mycophenolate was, after this trial, FDA approved for the management of SSILD. Refractory cases can have or can use rituximab, and this is a summary of meta-analysis of 20 slides with 575 patients that showed how rituximab was able to stabilize FVC and DLCO at 6 and 12 months in this study, and it's an agent that we use. Recently, there was a publication of the use of tocilizumab in the management of SS-ILD, interleukin-6 inhibitor. So interleukin-6 was found in high titers in patients with systemic sclerosis and mainly related to the ILD plus the skin manifestations of the disease. This trial was designed where patients who are not very sick, so have an FVC of sorry, on the other side, yeah, FVC was in the 80s, DLCO of 76%, so healthy ILD patients who had, so the criteria for involvement, they had to have the extensive skin disease. And the majority of them had high serologic markers of inflammation, so high CRP, ESR, and platelet counts. The study was negative in stabilizing the skin manifestations and reducing the skin fibrosis and thickness in these patients, but it found stabilization in the FVC in these patients, and the rate of decline for those who were on the interleukin-6 inhibitor was way better than the patients who were on placebo. So right now, in early stages of systemic sclerosis patients who have evidence of inflammation on serology, tocilizumab is FDA approved actually since March last year for that indication. And the last I'll talk about, which is also an FDA approved use in scleroderma, is the use of nintedanib, depending on the census trial, which showed stabilization of the FVC in a design similar to how it was done for IPF, so 52 weeks of observation with stabilization of the FVC in these patients on nintedanib compared to placebo. And basically, these are so far the FDA approved uses of medications in systemic sclerosis. I'll move to rheumatoid arthritis. And in rheumatoid arthritis, you may already know how what's the categories of pulmonary involvements for rheumatoid arthritis, and up to 60% of the manifestations of RA are in the lung, and usually and typically occurs after the articular disease develops. I submitted recently a case report to ATS with, I think it was, I don't know if it was you, Crystal, or somebody, but we had a patient who had ILD manifesting 6 years. You're right, Shraddha, thank you. ILD was manifesting 6 years before the serology turned positive and the articular manifestations of the patient developed. So it's, of course, this is the exception. In the what is specific about RA-ILD is what I'm going to mention in the next slide, but RA-ILD has more than the inflammatory component of the disease to cause the lung disease. There looks like to be a genetic predisposition, and that was proven by twin studies where there was up to 15% correlation of developing RA-ILD in twins. There is obviously the exposure and mainly to smoking that predisposes patients to higher risk of progression of ILD. And there are, of course, the autoimmune features of the disease in addition to some genetic predisposition that I'll talk about a little later on. In this cohort study, they differentiated patients with RA into having the typical radiologic UIP compared to non-UIP. And if you look into in that cohort and their demographics, they are very similar to what we see in IPF patients. An older male, previous smoker, who has low titers of CCP, so low titers of inflammation, has poor response to therapy. These patients actually now are called the RA-UIP. And of course, as you know, among all connective tissue diseases, RA is the most common disease to have radiologic and pathologic UIP compared to all other categories, where non-specific interstitial pneumonia is the most common. In this paper by Solomon of National Jewish, so they had their cohort in the clinic, and they assessed progression and survival of their patients with rheumatoid arthritis cohort compared to their patients, compared to the normal population. And then later on, compared their RA cohort to the RA patients who have fibrotic lung disease and found significant difference in mortality, of course, worse in the fibrotic lung disease. And later on, they did a case control study where they had rheumatoid arthritis UIP with age matching with an IPF cohort of their same clinic, and they saw very similar mortality and progression of the disease in this population. And that's what, as I said, is unique about RA-UIP compared to any other connective tissue disease related ILD. Now, therapy. There is no randomized controlled trials for treating RA-ILD. As I said, the predisposition is related to the environmental exposure, smoking in particular, genetic exposure, and the inflammation related to the disease. Talking about genetics, for example, the MUC5 gene, which is related and mainly associated with the pulmonary toileting or pulmonary clearance in the lung, is high titer in 50% of patients with IPF. It was found to be very high also in a subset of RA-ILD, especially RA-UIP, and in fibrotic HP. So that also gives similarity between these two disease groups. What I want to emphasize little on is the use of RA medications for the management of joint disease. You know, the DMARDs and the first-line therapies for RA, which includes methotrexate, leflunomide, anti-TNF alpha agents. So many of the DMARDs for RA are associated with pulmonary toxicity, mainly methotrexate and leflunomide. And there is, I think, enough literature to document that. Although recently, Mike got the journal club on the questioning method. Gaurav got a questioning methotrexate and lung and association with lung toxicity, but we do have enough literature to talk otherwise. I will mention briefly about biologic therapies in the management of RA. So they are of the first line therapies in management of the disease. And in the ILD clinic, we tend to avoid using biologic therapies, mainly for one reason, not the other. So was there a causation between developing new ILD in patients with RA who are on biologic therapy or not? Actually, a study of almost 8,000 patients retrospectively went back to all these patients who had biologic therapy versus other first-line therapies for RA, and the new development of ILD was only like in 0.5% of the patients. So putting patients on biologics is not going to increase the risk of ILD, but when patients come to our clinic with an established ILD or worsening interstitial lung disease on biologic therapy, there is no way we can keep the patient on the therapy, because whether this is caused by the agent or failure of the agent to control the lung disease, there will be a need to change therapy. And with that, the alternatives we use are rituximab, tocilizumab, like I showed for scleroderma, and rituximab are being good options to treat these patients, although CellCept in particular doesn't control the articular disease very well. I'll skip the anti-fibrotics because Asif will cover that, and I'll move to Sjogren's. What is unique about Sjogren's is the multiple pulmonary manifestations of the disease, in addition to the risk of lymphoma and mediastinal lymphadenopathies, pulmonary nodules that has the high risk of developing into lymphoma. 3 to 11% of patients with Sjogren's will have the tendency to develop ILD. And as I said, NSIP being the most common pathologic and radiologic manifestation of the disease. The risk of lymphoma is up to 10% of the patients, so we are always mindful of monitoring lymph node, ground glass opacities, nodular opacities in the lung, especially when we start patients on therapy, on immunosuppression. The the rate of repeating CAT scans is way maybe more frequent compared to other patients, specifically in that regard. I'll leave actually the survival information also to Dr. Abdelhamid. We're leaving you a lot. Therapies, mycophenolate mofetil was reported in multiple papers. This is one of them of 125 patients in early 2008, 2010 with stability of the disease. Mycophenolate is a relatively safe medication in that subset of patients. Here is another paper on using rituximab in refractory cases with also stability of the disease, and we just introduced to you in our multidisciplinary meeting a case that got stabilized on rituximab. And these are the other options that are being used, as azathioprine is one of the safe, frequently used medications that we do as well. The last category I'm going to talk about is myositis-related ILD. Myositis, as I mentioned, so while there are maybe 4 main categories of myositis, overlap myositis is as common as the 2 categories that are associated with ILD in our clinic. I just shed light here in this paper for the presence of ILD in categories of myositis, and you can see how dermatomyositis and antisynthetase syndrome are among the most common, in addition to overlap. I want you to always be mindful on ruling out cancer, specifically in dermatomyositis patient, where up to 30% of the patients can have this as a manifestation of paraneoplastic syndrome. And it's kind of a routine for us when diagnosing a patient newly with dermato or polymyositis is to have the age-appropriate screening, including CT, abdomen, and pelvis. Prognosis of autoimmune myositis. This is an old study but shows the better outcome for patients with poly and dermatomyositis compared to other categories of the disease. And this is a list of the treatments that are being used. As you see, there are no controlled randomized trials compared to other categories of CTD, but we tend to use similar regimen compared to what I showed you just previously with Jogren. We use safe medications with case series and reports in the literature of stabilizing the diseases. With that, actually, I'm going to move to the last component of my talk, which is if you have a patient who doesn't fit the criteria for any specific connective tissue disease-related ILD, and you don't think they have idiopathic pulmonary fibrosis or idiopathic interstitial pneumonia in general, and they have one component of of these 3 columns, meaning they have some skin findings or they have, some clinical exam findings of an autoimmune disease, plus at least 1 lab positive of this column, plus a radiologic pattern that tells you they don't have typical probable UIP, or they have anything on pathology to indicate they don't have the typical UIP. If they have one of each domain, then the research term that we call these patients is idiopathic pneumonia with autoimmune features. Now, this is a broad terminology because some of these patients present acutely to the hospital with steroid responsive disease, and we send them to rheumatology and there is no diagnosis. They are still in our mind called that terminology or that research term, which doesn't translate like into an ICD-10, but we say suspect connective tissue disease. If we have enough evidence, especially with steroid responsiveness, we can put these patients on immunosuppression. But if we get a patient with progressive fibrosis and still has one of these 3 domains, we may not offer them any of that. And they might just have idiopathic pneumonia, but with some positive serology. And that's what Dr. Lavaraja showed in her IPF talk. Here is a meta-analysis of the prognosis of patients with idiopathic pneumonia with autoimmune features, depending on this classification that I showed you. And this is a sum up of like 650 patients from 12 studies. There was no difference in mortality between IPF patients and IPF. But still, as I said, if such patients would come to clinic but have clinical scenario that suggests response to therapy, we may still have the suspicion that they have a connective tissue disease that is yet to determine or define itself, and they can be put on therapy. And if we don't have that, Asif will talk very soon about what to do, and their prognosis was not found to be different than IPF patients.
IPAP with the UIP pattern.
Yes, IPF, sorry, with the UIP pattern. Yes, thank you for clarifying. And with that, I want to thank everyone.
Close it, yeah, exit that one.
No, this is oh, this one. Yeah. Back to Dr. Savaraja with hypersensitivity pneumonia.
Thank you, sir. I don't see anything in the chat box. I wonder if people are asleep. Maybe. I don't know, Dr. Abusay. So let's talk about chronic hypersensitivity pneumonitis. So we've had some of the updates in guidelines already, same disclosures. And so we'll talk about the diagnostic classifications and the implications of that. And then I'll do a little bit of comparing the CHEST and ATS guidelines. So hypersensitivity pneumonitis epidemiology. So probably the highest prevalence in patients over the age of 65. And when you look at fibrotic versus non-fibrotic disease, patients with fibrotic disease tend to be older, tend to have an unidentified exposure, a lower vital capacity, a lower diffusion capacity, and a lower percentage of BAL lymphocytes. When we're trying to come up with a diagnosis, one of the things that we do to reassure ourselves is that for the most part, when we're diagnosing someone with ILD, they tend to fall into 4 or 5 different categories, and chronic hypersensitivity pneumonitis is one of the most common, and now we're going to call it just hypersensitivity pneumonitis. Looking at the pathogenesis. So this is a Th1 mediated disease. So occurs from repeated inhalation of antigens that are in various dusts, whether that's at work or at home, and or whether that's directly inhaled. And so the host factors are smoking, potentially polymorphisms in the TNF gene, and then their exposure factors. So antigen concentration, duration, and particle size all play into this. But there's an inflammatory phase and also a fibrotic phase. And in genetic studies trying to differentiate IPF from HP, there's an upregulation in genes for inflammation that's seen in HP that is not seen in IPF. The updated classification. So the prior one that we used was acute, subacute, chronic, but that doesn't really translate necessarily into prognosis and doesn't really help guide what treatment necessarily we should be using. So the new classification scheme is fibrotic versus non-fibrotic. So why does that matter? So fibrotic features, let's start with pathology. If someone has a biopsy, if they have features of fibrosis, so they have fibrosis, or FF is fibroblastic foci, and higher on the curve in the red is improved survival. But basically, patients who have worse features of fibrosis or fibrotic features at all have a worse prognosis. And this is a study looking at sort of differentiating that. When we look at the radiographic pattern, so if patients have features of fibrosis, if they have traction bronchiectasis, if they have honeycombing, those patients in the red here have a worse survival than patients who do not have features of fibrosis. And this is when you don't have a biopsy. So when a patient hasn't undergone biopsy, radiographs alone also predict that difference in mortality. And then when we look at patients who have hypersensitivity pneumonitis and have honeycombing on CT, those patients have a similar prognosis to IPF. And this was when this came out, I think that it really opened our eyes to things that we were experiencing, that we would see patients who had fibrotic features and on honeycombing, and we would watch them be stable for a year or two, and then we felt like the bottom would fall out, that these patients progressed rapidly. And I think this explains why that these patients do have a similar prognosis to IPF. It confirms what we see anecdotally. So looking at the diagnosis. So among different ILD centers, so this is looking at several different centers and what's the agreement in terms of a multidisciplinary diagnosis for disease. So you can see for IPF, that's the top row there, second row, sorry, that's not the total. So the second row there, that the agreement is actually pretty good in terms of MDD diagnosis. As you move down to hypersensitivity pneumonitis, it is not good at all. It is 0.25, 0.38 for a kappa is not a very strong agreement. And so this was one of the calls for why we wanted to look at, as a community, why we want to look at, geez, how do we diagnose this better? How do we have standardization in terms of how we approach this? So this is a basic overview, a suggested overview, and falls in line with a lot of what our group does here in terms of looking for exposure, a standardized way of looking for exposure. If identifying an antigen, and if we have a characteristic features of HP, potentially pursuing bronchoscopy to pursue diagnosis in these patients. And then for patients without an identified exposure, if HP is still suspected and it looks to be more fibrotic, thinking about how we could treat those patients either with a steroid-sparing agent or anti-fibrotic. So looking at the history and physical, our ability to obtain that exposure history is challenging. And in less than 50% of the cases, do we actually have an identified exposure? Some of the things that we look for as clues is if there is a relation, of course, between exposure and the development of respiratory disease, that's helpful. And then if there are inspiratory squeaks on exam, and that might suggest small airways disease or bronchiolitis, that would be atypical for an IPF exam. It's certainly not going to be enough for us to give a diagnosis, but does give us a clue that maybe we do need to look again at exposures. Looking at the assessment tools that we have, the use of a structured, this is looking at the opinion of multiple hypersensitivity pneumonitis experts and what they use to get diagnosis and what they think is important in terms of assessing the exposure. So using a structured questionnaire, whether or not there's improvement with antigen avoidance, an environmental assessment where someone goes in and actually does an investigation of either their workplace or a patient's workplace or home, specific inhalation challenge, which is that is being not recommended anymore because it's just challenging to standardize that, and also may have some negative effects for the patient to be exposed to have an aerosolized version of what they're already sensitive to as their exposure. Specific IgG testing, and that's really all over the place still. And we've in our group we've moved away from sending the hypersensitivity pneumonitis panel when there can be specific IgG testing to a specific antigen that is isolated from someone's environment. That may have a different role. Lymphocyte proliferation tests, because of the lack of standardization, the difficulty in performing that, that's also not routinely used. And then multidisciplinary assessment for, I think from all of these, it seemed to be one of the ways that's helpful. One of the things that again, that we've moved away from is BAL CD4 CD8 ratio. The classic teaching is that a low ratio is suggestive of hypersensitivity pneumonitis. We've moved away from that because that is so specific to non-fibrotic HP and maybe highlighting patients who would have spontaneously resolved. And so it doesn't necessarily have treatment implications. So we've moved away from using that. In terms of predicting who has hypersensitivity pneumonitis, and all these studies we take with a grain of salt because there's no standard of care. There's no diagnostic standard, really, or gold standard for diagnosis is a better way to say that. But when there's an exposure to a known offending agent, most can agree that that significantly increases the odds that that patient has hypersensitivity pneumonitis. And that, I think, is the big takeaway from this older study, but is the basis of why we look for specific exposures. So coming to the CHEST and the ATS guidelines, They differ really in one major way. So some of the terminology for the radiographs are just slightly different. And the other major difference is that BAL is not routinely recommended in the chest guidelines, but is recommended in the ATS guidelines. So we'll walk through the ATS guidelines next. And so when you have we'll walk through this one a little bit more. This falls a little bit more in line with what our group has been doing. But when you have a patient that's being there's a suspicion of ILD, suspicion of hypersensitivity pneumonitis, you've done your exposure assessment and chest imaging, and then you're using patients who have either typical non-fibrotic or patients with indeterminate, but maybe have a good exposure history. That's where BAL, looking for lymphocytosis of at least 20%, but depending on the study you read, maybe 30% might be a little bit more secure, and with or without transbronchial lung biopsy. And so then taking that information to your multidisciplinary discussion. For patients who don't have a typical CAT scan features, do not have BAL or transbronchial lung biopsy findings, those patients are labeled as having an unclear diagnosis. Multidisciplinary discussion again is pursued, and potentially some of those patients do have a high, will be given a high confidence diagnosis of IPF, but that's where we start to consider whether transbronchial cryobiopsy or surgical lung biopsy might be helpful in these patients. So we'll go through kind of try to give some examples, but these I know are a little bit dense to get through. So this one. Okay, so when looking at what's where those patients fall into on that prior algorithm, we have typical, compatible, and indeterminate for HB, and you can have typical fibrotic and typical non-fibrotic features, which Dr. Bamoudi went through, and I'll highlight just a little bit. And so I'm going to actually move down to where we have an example, because I think it makes it a little bit easier. So when you look at someone, let's say they have a bird exposure, they have diffuse ground glass with air trapping. So that's a typical feature of hypersensitivity pneumonia. And let's say you did do BAL and that patient has 40% lymphocytes. So that would put us into a person with typical HP features on radiograph, a positive exposure, and BAL lymphocytosis. And most would agree that that patient has, that we would feel confident that patient has hypersensitivity pneumonitis. What the chest guidelines will argue is that if you already have a positive exposure and you have typical findings of HP, do you really need that BAL? And that's where things differ. We'll sometimes use that BAL lymphocytosis to help drive whether or not we're going to use immunosuppression or not. Okay, and so let's go through another example where there's no identified exposure, but there's this 3 density sign, and I'm going to move back to that to show it to you. And no bronchoscopy is performed due to comorbidities. That's someone that's low confidence. So that patient had 3 density signs that in these guidelines is compatible but not typical for HP. And because we couldn't form the bronchoscopy, we don't know about lymphocytosis. So this would be a low confidence. It doesn't mean that you can't give that patient a diagnosis of hypersensitivity pneumonitis, but again, not as convincing as that other scenario. Let's move back to that 3 density sign. And so as Dr. Bamoudi described to us, you should see ground glass, areas of lucent lung next to areas of normal lung. And this does have clear demarcations, areas that are involved and not involved. And then it does look like it gets worse when that patient does exhalation. So inspiratory imaging, exhalation imaging. And so we've moved away from using that terminology head cheese sign and now moved to 3 density pattern. Okay, so does it matter which guideline you use? And there's actually been a group that used a series of cases that there was suspected hypersensitivity pneumonitis and applied both the ATS criteria and the chest criteria. And there was actually quite good agreement. So this is, I think, reassuring that at least that whichever one you feel more comfortable with using, you're not going to be, it's not so different from the other guidelines. So there is a lot of similarity there. Okay. So moving on to management. So what's been looked at in hypersensitivity pneumonitis are areas targeting the inflammatory phase and those targeting the fibrotic phase. So what we'll talk a little bit about are antigen avoidance, systemic steroids, steroid-sparing agents, anti-fibrotics, and lung transplant. So this study, I put in here what the patients look like in this study because this is actually the largest series of hypersensitivity and pneumonitis patients studied. And so you look at patients with non-fibrotic versus fibrotic disease. The patients with non-fibrotic disease tended to be younger and tended to have higher percentage with BAL lymphocytosis. And of course, none of them had honeycombing because they were non-fibrotic disease. Not all of these patients were discussed at a multidisciplinary meeting, and corticosteroids are actually used in about 80% of both groups, and with much less of them being given steroid-sparing agents. So antigen avoidance improves lung function in non-fibrotic HP, but not in fibrotic HP. So on the left-hand side here, you have FVC percentage, and I'm sorry, it's not FEV1, DLCO percentage. And both of those you can see were the green after the patient had avoided antigen, that FVC improved. For fibrotic HP, you might have seen some stabilization, but certainly not improvement. But there still may be some value for antigen avoidance in fibrotic HP. Antigen avoidance does not improve survival in HP. When you look at the green, which is exposure terminated, versus red, exposure active, it didn't improve survival. One of the things that we may not be able to detect well if it helped was the mortality was low in the non-fibrotic group. And so did antigen avoidance help them not have disease progression and go on to fibrosis, which we might not have seen for even a longer period of time. So it's a little bit hard to fully interpret that, but technically from this study, we're not seeing a dramatic improvement in survival if you avoid antigen. Corticosteroids also do not improve survival in HP. And this goes back to teaching. I remember when I was a fellow that we would talk about this, and we actually moved away from, we wouldn't give a lot of steroids because we felt it didn't improve survival, didn't change outcomes. For when you look at fibrotic and non-fibrotic on the left together, no corticosteroid treatment is in green, and that's very similar to patients on corticosteroids. In fibrotic HP, even though they do look like they're separating the curves, they're not statistically significant. There was not a survival improvement. So what about lung function? It does look like in non-fibrotic HP, steroids improve function. And this makes sense. So if you have someone that comes into the hospital acutely ill, maybe needs a few liters of oxygen that you give systemic steroids to with that strong exposure history, maybe you've done the BAL on them, and you can see improvement, stabilization and improvement. For fibrotic HP, corticosteroids do not improve lung function. And this goes along with that fibrotic phenotype that maybe corticosteroids don't have as much of a role here. Looking at azathioprine or mycophenolate mofetil, neither are FDA approved for this indication. But when you look at these, they do actually help improve the amount of steroid that someone is on. It allows you to taper steroids. So there likely is some role here, unless you're thinking that for a non-fibrotic fibrotic patient, it may not have made a difference and they should be off of the steroids anyways. But regardless of that, it does show that the patients on either of these medications allowed for taper of the prednisone. When you look at what happens to those patients in terms of lung function, FVC is on the left, DLCO is on the right. Patients over a 12-month period of time had stabilization of their FVC and mild improvement in their DLCO on steroid-sparing agent. And this includes fibrotic patients, and this is where that thought of using a steroid-sparing agent, even in a patient with fibrotic HP, comes from. Dr. Abdul Hamid will be talking about this more, but when you look at the subgroup analysis for patients moving to anti-fibrotics, For patients with hypersensitivity pneumonitis, there was an improvement over those receiving placebo in terms of stabilization of FVC and specifically in fibrotic HP. And then moving to other things that we are still able to do for patients, lung transplant in HP. So if you look at patients who have IPF, which is the solid black line in the graph on the right, versus the dashed line, which are the HP patients, and you look at survival, the survival post-transplant is quite good in patients with HP. One of the other things that's come up, there's case reports on it, but there's not a lot to kind of show what happens to these patients in terms of recurrence, but there is a potential for recurrence of HP. So if we are able to identify an antigen, you could argue that that should be part of the transplant process, that antigen avoidance, to prevent recurrence. But this shows that it's an option for patients and that it can improve survival. And then again, here's that suggested diagnostic approach. Here's a suggested treatment approach. And I think the only place that we differ is probably the use of systemic steroids in what looks like to be more fibrotic HP. If it looks like a mix of non-fibrotic and fibrotic, we will try lower dose systemic steroids. In either case, we will also look at steroid sparing agents for these patients. But in a patient who has what looks like purely fibrotic disease, we have moved away from using systemic steroids. And especially if we're stuck between a diagnosis of potentially hypersensitivity pneumonitis versus IPF, we will avoid steroids because we know the long-term side effects especially for a patient with IPF, the morbidity, mortality is higher. We'll avoid steroids in that situation as well. And so in summary, HP hinges on our combination of an exposure assessment, radiographic patterns, and plus minus pathology, plus minus also lymphocytosis. Non-fibrotic versus fibrotic HP carries prognostic and treatment implications. MDD aids in reaching a consensus diagnosis. Antigen avoidance and corticosteroids don't improve survival, but can improve lung function. And then the steroid sparing agents may stabilize lung function. And consideration of anti-fibrotics and lung transplant referral in patients with fibrotic HP is also warranted. That's everything I have for this one. I thank you guys. I felt like that was the most dense. That was going to be the most dense one today.
What is the most common antigen? Some of the more common antigens you have identified since you've worked in ILD?
Yeah, so we got surprised at how frequent we still find people with birds. Birds become a member of the family. Often there's more than one bird, but sometimes we'll also still see hot tub, and then water damage to the home, mold, and oftentimes it's already been remediated, but if we get concerns that they already have features of fibrosis. Anything else? Yeah.
When you're seeing a patient that is developing fibrosis, but not necessarily
Absolutely. Yeah. And so the antigen avoidance doesn't improve survival. So if we can find them earlier than that, I think to me, it means that and that's what we've experienced, that the patients will have removed it or say, oh, I moved out of that house, just like the patient we presented, for MDD. She had moved out of the house. She was away from it, already had features of fibrosis and continued to progress. So we still, if there's any, we still advise it. And then if that person's a transplant candidate, if it's fair for the transplant team to say, look, there's a potential of you recurring after transplant, we need to address this.
You're not able to identify they're going to the fibrotic. Did you consider the candidate for transplant?
Yes, absolutely. Yeah, we still refer. They're still looked at. Absolutely.
And that lung is never seen. Is it the same process that would happen?
Oh yeah, no, that's what's described. Again, case reports that you can have recurrence of HP, even on all that immunosuppression. But we've not, I don't know that we've experienced it here, at least in our group, we've not, but again, just case reports.
Just to add to your question, up to 50% of the cases.
Yeah, we
some
can't identify it.
clinicians cannot
Yeah.
identify what's taking that. So we give a diagnosis of
Mhm.
HP, but 50% they may not
Okay, in the interest of time, we got one more. It looks like Crystal has been waiting. Oh. Oh, we think there is a genetic predisposition. In some cases, yes, it has. There actually is some identification, but it's not something that we're specifically testing for. But that might be a future way. Are we taking a brief break, right? Brief break before also?
now or
Yeah, I think it's now.
after us.
It's up to you guys in the room. The people who are on virtual can get up and take a break whenever. But they have the liberty of that. So we can either take 5 minutes now, or we can have Dr. Abdul Hamid give his talk and then do a brief break. I think I would do the break now. So we group the last three and then we're done. Okay. I'm sorry, I've decided for you. I should not have asked. I'm sorry. All right, anyone who's on virtually, we're going to go ahead and get started with Dr. Abdul Hamid's talk on progressive pulmonary fibrosis.
Thank you, Dr. Raja. So for those who don't know me, I'm Asif. I'm one of the third-year pulmonary critical care fellows here at Henry Ford, and I'm going to be talking about the new terminology, progressive pulmonary fibrosis. I have no disclosures. I forgot to put in a disclosure slide, but I have no disclosures. So the outline of my talk is going to be, we'll first discuss a little bit of historical perspective on what progressive pulmonary fibrosis is and how we came to this at this juncture. Define and describe the diagnostic criteria from the most recent guidelines that were published earlier this month. We will also discuss the different ILDs that manifest as progressive pulmonary fibrosis, the epidemiology, pathophysiology, the assessment of disease progression, and then we will also talk about the treatment considerations that we have. So in terms of the historical perspective, within the ILD community, we have this debate of whether to lump ILDs or to split ILDs, and so-called the lumpers versus splitters debate. If going back in time in the past, this is from the textbook of Principles and Practice of Medicine from the 1800s by Dr. Osler, right? This was one of the first descriptions of interstitial lung disease as essentially cirrhosis of the lung. So in the past, we lumped disorders, lumped in different interstitial lung diseases into a broad category of pulmonary fibrosis. Now, what did this do to impact treatment, prognosis, treatment decisions, things like that? Lumping leads to a lot of heterogeneity. As we know, interstitial lung diseases are very heterogeneous. So lumping will lead to a lot of heterogeneity, and hence it's difficult to study interstitial lung disease when you lump them together, because the treatment response would differ. If you go back and look at some of the old retrospective data about corticosteroid use in interstitial lung disease, we saw that patients who responded best with corticosteroids were young females with a pathology that was more descriptive of being cellular rather than fibrotic. And if I were to ask for a show of hands, you would probably say that these patients had an SIP. So lumping, as you know, just to reiterate, leads to a lot of heterogeneity, and hence difficult to study. So subsequently, we started splitting interstitial lung diseases. This was one of the first described splitting of interstitial lung disease by Lebo and colleagues back in the 1970s. And this was more of a pathological classification of interstitial lung disease. Splitting did helped us in paying more attention to diagnosis. So the emphasis now was on diagnosis, since different diagnoses had different prognosis and different diagnoses were treated differently. So the emphasis now fell upon diagnosis itself. But subsequent disease behavior is not addressed. So when we split disorders essentially into different categories like idiopathic interstitial pneumonias, interstitial lung disease secondary to a specific cause, it also helped us in success with our clinical trials, specifically the clinical trials for anti-fibrotics, both nintedanib and pirfenidone in idiopathic pulmonary fibrosis. And subsequently, we published consensus statements and guidelines for IPF, specifically over time. And this leads us to where we are right now. So as I mentioned, so we have the lumpers in the past, and then over time, we started splitting interstitial lung diseases. But then we had the success of our clinical trials with IPF, with anti-fibrotics and IPF. But how about the utilization of anti-fibrotics in ILDs other than IPF? And also, when we look at different interstitial lung diseases down the line, which is after diagnosis, 6 months after the point of diagnosis, the FVC decline and the decline in diffusion capacity has very important prognostic significance. So this actually led to the landmark trial, which was published in the New England Journal in 2019, which is the INBIL study, which showed benefit of using nintedanib, which is one of our anti-fibrotics, in ILDs other than IPF. So this basically led to a paradigm shift. So now we move towards a paradigm shift towards more of an en bloc approach, essentially, in a sense, going back to lumping, but more so dependent on subsequent disease behavior rather than at the time of diagnosis itself. So this is where we are. So the earlier this month, we had the American Thoracic Society along with the ERS, the JRS, which is the European and Japanese Respiratory Societies, we have a new guideline in which we describe and define pulmonary fibrosis with the what is called as the progressive pulmonary fibrosis itself. Now, before I talk about progressive pulmonary fibrosis, I also want to point out that if you look at the literature on progressive pulmonary fibrosis, there are two other important terminologies that can be confused, but essentially mean the same. One is something called PF-ILD, which basically is progressive fibrosing interstitial lung disease. And the other is pulmonary fibrosis with a progressive phenotype, with the emphasis on the word phenotype. All of these terminologies are the same, but for the purpose of our talk today, I'm going to stick to the terminology progressive pulmonary fibrosis, since this was defined in the most recent guidelines. So what is this? What is this terminology of progressive pulmonary fibrosis? So progressive pulmonary fibrosis, by definition, is an ILD with a known or unknown etiology, with certain important things to consider. Number one, this is other than IPF, right? So this is progressive pulmonary fibrosis, which is other than IPF, which is defined by having at least two of these three diagnosis criteria. So what are the three diagnosis criteria? A, having worsening respiratory symptoms. B, physiological evidence of disease progression. And this is where it's important to recognize what the definition of physiological progression is. And this is an FVC decline of more than or equal to 5% within 1 year preceding. And then also an absolute decline of corrected hemoglobin corrected diffusion capacity by more than 10% in 1 year. And C, looking at the radiological evidence of disease progression. And I know Dr. Gumidi went over different, different definitions of what radiological progression means. But just to reiterate, it can be the increase in the extent or severity of the off-traction bronchiectasis or bronchiolectasis. It can mean new ground glass opacities. It can mean new fine reticulations, increase in the coarseness of the reticular abnormalities that you're seeing, new or increased honeycombing, and increased volume loss. So any one of these would qualify for the diagnostic criteria of having radiological progression. So 2 out of these 3 would give you a diagnosis of progressive pulmonary fibrosis in ILDs other than IPF in the past 1 year. The other important thing to recognize is that there should be no alternative explanation to these findings, right? So if someone had an obvious alternative explanation to, even with this, you would not technically call them, they would not technically qualify for the diagnosis of progressive pulmonary fibrosis. Where does this definition actually come from? This definition actually is reflective of clinical criteria that were used in some of the most important clinical trials we have for the use of anti-fibrotics in interstitial lung diseases other than IPF. And we will go over some of the 3 of the 4 that have been listed here in more detail in subsequent slides. But as you can see, the clinical criteria that were used as inclusion criteria for some of these studies were very different. You had FVC declines of 5 to 10%. In some, you had some of just having a 5% decline. And in some studies, but overall, it was usually a combination of one of the 3 things that we talked about. So symptoms, radiological, and physiological progression, typically 2 of the 3. Any questions right now in terms of just understanding the definition and diagnostic criteria we have for progressive pulmonary fibrosis? Okay. Moving on to what ILDs manifest as progressive pulmonary fibrosis. Now we know that a lot of interstitial lung disease across different categories can present as progressive pulmonary fibrosis. So you have the idiopathic interstitial pneumonias to the left, wherein you have idiopathic NSIP. Again, just to reiterate, IPF is an idiopathic interstitial pneumonia, but you would not call that progressive pulmonary fibrosis, even though it is the prototype of pulmonary fibrosis. It would not come within the definition of progressive pulmonary fibrosis. Connective tissue diseases, ILDs, again, with the colored portion representing essentially the percentage that can present with progressive pulmonary fibrosis, so systemic sclerosis being an important diagnosis there. Exposure related, Dr. Tavraja talked to us about hypersensitivity pneumonitis and other occupational lung diseases, and also not to forget sarcoidosis being another important diagnosis, other important interstitial lung disease that presents with progressive pulmonary fibrosis. Looking at the specific clinical characteristics of the different ILDs that can manifest as progressive pulmonary fibrosis, I think it's really important to point out that this is different amongst different interstitial lung diseases. IPF, I just put it in there. It's not PFF. I'm sorry, it's not a progressive pulmonary fibrosis, but it is the prototype of pulmonary fibrosis. And we see that in IPF, as Dr. Raja had talked earlier, the median survival is 3 to 4 years, with almost 90 to 100% of all IPF presenting with progressive pulmonary fibrosis, as opposed to other interstitial lung diseases. So, for example, the unclassifiable ILDs, I know Dr. Abusef talked about IPAF, technically, which would be within the category of unclassifiable ILDs, can have almost half of your unclassifiable ILDs can have the progressive fibrosing phenotype as a presentation. But overall, I think the takeaway from this slide is that patients with ILDs with a progressive fibrosing, progressively worsening fibrosis have worse mortality. Looking at the epidemiology, so how common is this entity, right? So this was a study that actually looked at, this was just a survey of physicians of pulmonologists, rheumatologists, and internists who take care of ILD patients. And the overall consensus is about 13 to 40% of all ILDs can manifest with the progressively worsening phenotype. In terms of real world studies, we see that this was the PROGRESS study that was published. This was a French cohort. So of about 1,400 patients that they looked at, we see that almost 27% patients had progressive pulmonary fibrosis. This was another UK cohort study that was published in the European Respiratory Journal of almost 2,400 patients. We see that 15%, almost 15% have progressive pulmonary fibrosis. So when we look at the pathophysiology, right? So right now, going back to the lumping, the splitting, and now back to kind of lumping based on subsequent disease behavior, what is really important to recognize is there is an overlap. So a lot of the interstitial lung diseases in the late phases have overlapping pathobiology, and hence they have similar disease behavior. So when we look at the pathogenesis itself, we kind of split this into the early stage and the late stage. With the early stage, you have typically similar overlapping risk factors that can put an individual with interstitial lung disease at risk for developing the progressively worsening phenotype. And typically you have various inflammatory responses that lead to a pro-fibrotic environment. But in the late phase, the current concept is that there are shared mechanisms and hence shared treatment targets, essentially, that can be utilized for the management of progressive pulmonary fibrosis. Going back to kind of answering one of the questions that was raised earlier is what leads to certain such as HP diseases such as HP in some patients with HP they have the same exposures, but they don't develop fibrotic ILD as opposed to some other patients. One of the things that we know is certain genetic predispositions, including the MUC5 gene and the telomeropathies, essentially have been known to cause interstitial lung disease, or rather even progressive pulmonary fibrosis, essentially, in not just IPF, but also in diseases such as rheumatoid arthritis and chronic HP, although we should be calling this fibrotic HP now. How about specific risk factors, right? So we talked about the different ILDs that can manifest with progressive pulmonary fibrosis. If we look at specific risk factors, I think there is some variability as to in different interstitial lung disease, you have different risk factors for developing progressive pulmonary fibrosis. But overall, the general consensus is typically patients are male, older, individuals who have honeycombing right off the bat. When you see them, they have honeycombing, or they have a CT evidence of more than 20% involvement, and also low FVC and DLCO at the time of onset are at risk for having the progressive pulmonary fibrosis. So we talked about different ILDs that come in, they have progressive pulmonary fibrosis, and we talked about the definite criteria that we have from the most recent guidelines, and that is we have the symptoms, radiological progression, and physiological progression. But how about everything else? I think it's still important, despite the guidelines. It's still important to have a sense of clinical gestalt here and have a multimodal assessment of how disease progression is. So disease progression may not be limited to what we already have in the definition, but can also involve things such as, did this patient have an acute exacerbation? How has this affected their quality of life? And just a global impression of how a clinician, who's been following a patient for years together thinks about a patient's progression of their ILD. Although these would have not been specifically addressed in the diagnostic definition, but I think these are some important things to consider. So after kind of having this, a background about different ILDs, just talking about in general what would be the management of progressive pulmonary fibrosis. And I think this is a very important thing to consider, because the question keeps getting raised that, now that we have anti-fibrotics to treat, now we have the definition. We have the definition to say that different ILDs across different, categories can manifest with progressive pulmonary fibrosis. And we have definite diagnostic criteria to call diseases to call certain diseases as progressive pulmonary fibrosis and treat with anti-fibrotics. But then that should not stop us from actually, working towards emphasis on diagnosis, because diagnosis still has treatment implications. So even though anti-fibrotics are used across a spectrum of ILD, the cornerstone of management still remains what we already know really well. So for example, in patients with chronic HP, or rather fibrotic HP, hypersensitivity pneumonitis in general, antigen avoidance and antigen eviction is still the cornerstone of treatment. In connective tissue disease, ILD immunomodulation is still the first line of treatment. So steroid-sparing agents. And just to kind of talk about the different steroid-sparing agents, I know Dr. Pusev described this in quite detail. Just to reiterate some important points, if you look at scleroderma, your first line management would be drugs such as mycophenolate, cyclophosphamide, and tocilizumab, which in the FOCUS and FASCINATE trials had shown significant decline in FVC. And across other, interstitial lung diseases, like specifically connective tissue disease, ILD, you have different other immunomodulatory therapies that are used. But overall, once you have addressed and treated with the first line agents, patients who have progression, they would be candidates for anti-fibrotic therapy. And the buck does not stop at anti-fibrotic therapy, right? So we also have to address the non-pharmacological treatments, which we will talk about in subsequent slides, and regular follow-up and seeing if this disease is now stable. Is it showing worsening? What are the things that we need to do for our patients to look at this? So any questions till now about, just the overall treatment, diagnosis, definition criteria? Moving on to the landmark clinical trials that we have for progressive pulmonary fibrosis. As I mentioned earlier, we'll be talking about for nintedanib, we'll be talking about the INBUILD study, which was published in the New England Journal in 2019. And for pirfenidone, we will talk about two other studies. One was by Toby Maher, which is pirfenidone in unclassifiable ILD, and the other is the RELIEF trial. So we'll be talking about these three big studies. So looking at nintedanib, this was first studied, was a landmark trial for anti-fibrotics in progressive pulmonary fibrosis, randomized, double-blind, placebo-controlled trial in 15 countries. We randomized patients to receive nintedanib versus placebo, with our primary endpoint being annual rate of FVC decline at 52 weeks. So the FVC decline that we saw was with nintedanib was about 80 cc's a year when compared to 187 cc's in the placebo group, with a between group difference of almost 107 cc's per year. And with this being a positive, and when the patients were stratified based on whether they had a non-UIP versus a UIP phenotype, patients with a UIP phenotype actually had a more significant between treatment difference. So with this, nintedanib got FDA approval for treatment of progressive fibrosing ILD, essentially, which is progressive pulmonary fibrosis. But also the INBUILD study shows that, gave us another really important, it also gave us more information that was also very, very important. And that is that it provided us with an insight into the natural history of progressive pulmonary fibrosis in general. This study basically looked at the patients who received placebo within the INBUILD study and compared it to patients who received placebo in the INPULSIS trials, which was the IPF trials. And what we saw was the rate of decline in both the placebo groups with IPF and progressive pulmonary fibrosis was similar. So progressive pulmonary fibrosis, this basically supports the hypothesis that progressive pulmonary fibrosis, regardless of diagnosis, has similar pathobiology and disease behavior to IPF. This was also, Dr. Tavraj, I think, talked about this earlier too. The study basically looked at the patients within the inbuilt trial and stratified them into 5 different interstitial lung diseases: HP, idiopathic NSIP, CTD, ILD, unclassifiable, and others. And what we saw was the effect of nintedanib on reducing FVC decline was consistent across the 5 subgroups of ILD. Moving on to the, this was the trial which was published by, so now we talked about nintedanib. Moving on to pirfenidone. In terms of pirfenidone, we have 2 different studies to talk about. The first one is this study, which was published in Lancet Respiratory Medicine in 2020 by Toby Marr. And this, they looked at patients with unclassifiable progressive pulmonary fibrosis. Again, randomized, double-blinded, placebo-controlled trial, 70 centers. They were randomized to receive pirfenidone versus placebo, with the primary endpoint being change in FVC at 24 months. If you remember, the inbuilt study was 2 years. This was 24 months. It was 2 years too. But I think it was, but they looked at 52 weeks rather. This was 24 weeks. Here, basically, what they looked at, it was 24 weeks, I'm sorry, 24 weeks, not 52 weeks. So this was 24 weeks, so 6 months essentially. And here, the primary endpoint was actually looking at daily home spirometry changes. Now, this study was negative from a primary outcome standpoint because there was a lot of intra-individual variability in home spirometry, as can be expected. So in terms of the primary outcome, this was considered a negative study, but one of the secondary outcomes they looked at was inside spirometry. Patients who received pirfenidone had a lower FVC decline when compared to placebo, with the treatment difference being about 95 cc's. So trend towards improvement, but negative study because the primary outcome was not positive. The second important study for pirfenidone is the RELIEF trial. This was, again, a randomized double-blind placebo-controlled trial in 17 centers in Germany. Again, randomized to receive pirfenidone versus placebo, with the primary endpoint being FVC decline at 48 weeks. And this study was actually, because this was around COVID time, so they could not really recruit patients at a good pace. So this study was actually prematurely terminated because the interim analysis showed futility, which was triggered by slow recruitment. But what they did was when this was published again in the Lancet Respiratory Medicine 2021, they provided different statistical imputations to address the missing data. And overall, all the statistical imputations favored the pirfenidone arm. So in summary, we talked about the first one was the inbuilt study. The second is unclassifiable ILD progressive pulmonary fibrosis by Toby Marr. The last one was a RELIEF trial. The first one was a positive study in terms of nintedanib, which led to the FDA approval of nintedanib in progressive pulmonary fibrosis. Whereas the subsequent 2 trials, although the primary outcome was negative and the second one was halted because of slow recruitment, showed that a trend towards improvement in FVC decline with pirfenidone. So this led to the treatment recommendations within the newest guideline. So for nintedanib, there is the guidelines suggest nintedanib in treatment for patients with progressive pulmonary fibrosis. Again, it's very important to focus on the point who have failed standard management for fibrotic ILD. So diagnosis is still extremely important. Cornerstone of therapy still remains, things such as immunomodulation for connective tissue disease, antigen avoidance for HP. But if they have failed standard management, then we would proceed with anti-fibrotic therapy. And again, that definition of standard management, as I described, differs from patient to patient. And they also recommended further research in not just in, specifically in subcategorizing ILDs and looking at the effect of nintedanib in different ILDs. For pirfenidone, though, because we don't have a positive primary outcome study, essentially for now, the guidelines recommend further research in pirfenidone in the management of progressive pulmonary fibrosis overall. So to kind of sum it all up, the care for our patients with progressive pulmonary fibrosis is not just limited to anti-fibrotics. I know we talked about anti-fibrotics a lot, but it's overall, addressing pulmonary rehabilitation, supplemental oxygen therapy, lung transplant evaluation when needed, patient education. We have excellent resources with PFF, within the PFF website for patient education, utilizing all of these resources. Symptom targeted therapy, again, for cough is such a big thing with our pulmonary fibrosis treatment. With our pulmonary fibrosis patients, so addressing cough, addressing other symptoms, and other non-pharmacological therapies. So in summary, progressive pulmonary fibrosis is a phenotype that can occur across many ILDs. There are many factors that play a role in ILD disease progression. Anti-fibrotic therapies, which target shared aspects of fibrosis across ILDs, are being utilized and are a viable treatment option, but standard ILD therapies remain the cornerstone of therapy. I'd like to acknowledge Dr. Tapraj and Dr. Busse for helping me with this. And just to reiterate, we are a PFF care center. And thank you, and I'd be taking any questions.
Okay, Heather's gonna go ahead and get started. I would just, you could do this or this, and then I wouldn't point, I would just talk.
Yeah.
Okay.
So hi, everybody. My name's Heather. I'm a nurse practitioner with the ILD team here at Henry Ford Hospital. I've been part of the team here for 6 years, actually worked a couple years in internal medicine as an NP. Before that, I worked 16 years as an RN. A lot of it was here in the MICU. Recently, Dr. Thavraja and I were part of a national team that helped write up the palliative care statement for the Pulmonary Fibrosis Foundation. That can be found on their website, and we'll talk about some of those points a little bit today. Okay, some of the objectives we'll talk about today: what is palliative care, how can it be helpful, symptoms, how to access, a couple of research studies, and a few case studies as well. So what is palliative care? The definition, this is a review, but it is a specialized care for people living with a serious illness that can improve quality of life by providing relief from symptoms and the stress of illness. Palliative care can be very important to remember in pulmonary fibrosis, whether it's idiopathic pulmonary fibrosis or one of the other numerous types of ILDs. They may have progressive, often unpredictable, and terminal course, with a lot of symptoms that go along with that. So why would we use palliative care? Of course, it can augment the management of patients with pulmonary fibrosis by addressing the symptoms, supporting caregivers, and aiding end-of-life planning. Many studies have shown that only a minority of patients who die from pulmonary fibrosis receive palliative care services. And most of the services they get has been found to be in the last few months of life. In other serious illnesses, palliative care has been found to increase quality of life and survival, actually. Patients with IPF usually follow one of three paths, like we heard earlier today: subclinical IPF, slowly progressive IPF, or rapidly progressive IPF with a shortened survival. So how would I introduce a topic of palliative care? It's never too early to ask the patient what's important to you. That's a good way to start the conversation sometimes, because we're often surprised at what the patient will tell us at that point. As mentioned, studies have shown that palliative care is underutilized in any patient with lung disease, and specifically with pulmonary fibrosis. A lot of them, like I said, don't receive a formal referral to palliative care, despite how poor their prognosis can be and all the symptoms that they're having. It can be really difficult to talk about palliative care initially because they are coming to terms with facing this uncertain future. Due to they have really never heard of this disease before, they're very shocked to hear about it in the beginning. They're talking about decisions about drug therapy, pulmonary rehab, clinical trials, or maybe lung transplant. So they're very overwhelmed at the beginning. So that takes a lot of time, but sometimes it leaves little time for addressing palliative care. But despite all these obstacles, the task force that we worked with recommended talking about it very early in disease, if possible. Patients really want to know what the future might hold for them and how they might face it. And it's good to let them know that palliative care can provide this extra layer of support for physical symptoms, also spiritual, emotional, psychological, and social needs as well. And then, of course, it includes not only treating their symptoms like cough and dyspnea, but all these other aspects of their disease as well. So we recommend to address it early in the disease. The concept of the medical journey with our patients, which can vary from patient to patient, of course. Identifying these needs early can prompt referral for counseling, cognitive behavior therapy, and then move more into formal psychiatric help if that is needed, and then other emotions and spiritual needs as well. And then home assessments can be checked into at that time too. It can connect patients, if you refer them early, it can connect them quite quickly with organizations that will partner with them for the rest of their illness. So what does it offer to these patients if they're referred early? Just adding more to what we already talked about. Discussions may offer the reassurance that resources are out there for them that can help them manage their symptoms, and then will help them with future care planning, even though they might not want to really hear about it right away, but they will at least know that it's available for them in the future. It can really offer them like the peace of mind when they face their uncertain future. And just again, knowing that it's not going to work for everybody. I think we all have a sense that some people who do not want to hear anything about that. And it sometimes takes weeks and months for them to come like with the grips of what they're facing. Now, if palliative care is offered later in disease, it's still good. It focuses more specifically on treating their dyspnea, treating their cough, their anxiety, and all the symptoms that they're facing. And then just to mention that studies have shown that patients with end-stage pulmonary fibrosis report worse dyspnea than people with end-stage cancer, but yet they get fewer referrals and fewer medications to help out with that. So just something to keep that in mind. Just to review, what are the differences between palliative care and hospice? The palliative care is a more comprehensive care, focus on the well-being of the patient. It doesn't replace the medical care, the medical decision-making that's been going on with the pulmonologist and the team, but it actually aims to improve the quality of life at any stage of the illness, so it can be introduced at any time. And then it gives the patient a chance to live as fully as possible, even if their disease is limiting them. But hospice is more, of course, the end of life care. It focuses on alleviating the suffering that the patient is going through. And it's usually introduced when it is known that they have about 6 months to live. Many institutions have palliative care consult available, as we do, for both inpatient and outpatient. There are also many programs out in the community as well. So various bridge programs are available, offering all sorts of services that the patients may need and could use from, and the family as well. So we would advise any team that's taking care of these type of patients to explore this type of services that you may have out in your community and at the institute that you're working at. And then that can facilitate an early referral if needed. Support groups, they have been used a lot with patients with IPF and ILD, and it's kind of a venue for disease education, patient and caregiver communication, oxygen therapy, emotional support, and advanced care planning. They talk about everything under the sun that could benefit them. They're meeting other people that are going through the same thing as they are, of course. It also is helpful for caregivers as well, and they can interact with clinicians and other patients, of course. So our ILD clinic is working right now to start a program, a support group program in collaboration with the Pulmonary Fibrosis Foundation. And that will serve our patients in the Metro Detroit area. And that should be hopefully completed or started up by the end of the year, is our hope. This is a little article that was written by Jeffrey Swigers out of National Jewish. And it was talked about these transitions and touch points. It's just another way to look at palliative care. So it's not a long article, but it was just a really interesting one. He talks about 4 major touch points throughout the process of of IPF. He talked about, well, first of all, the definition of a touch point was a time, condition, or circumstance that is vulnerable or unstable enough to precipitate a highly unfavorable, possible devastating outcome. And that was from the English Oxford Dictionary. So these 4 touch points are, and the first one is when the diagnosis is given. And then the last 3 talk about oxygen a lot, and that's the way he just looked at his patients. So then the next touch point was when oxygen was prescribed for the first time. They're using it on exertion. The third one was when oxygen is needed at rest. So they're needing it more now. And then the last one was when high flow oxygen was needed. So they needed it basically all the time. And so he talked about that, and he talked about introducing conversations at each of these particular points in the patient's journey. Some additional points just to mention, some have already been talked about. Patients with ILD have such a wide range of diagnosis. So of course, we would recommend that they would be seen early in evaluation at a pulmonary fibrosis care center, which we are one, as was mentioned before, but there are many across the US. As well, early transplant evaluation, of course, if the patient is interested in that and they're a candidate for that, that should be talked about early as well. And then connecting patients with access to clinical trials as early as possible as well. Just a couple of case studies to talk about a few of the patients we've seen lately. The first one was a 88-year-old gentleman. He lived on a farm, took care of the entire farm, all the land, and he also took care of his family and his wife who had many medical issues. He did take part in our clinical trials here, but he had just a severe cough and shortness of breath, which continued to be such a burden for him. Every time that we've seen it, it was just always an issue. He was very resistant to any palliative care. And he didn't want it at all, but we thought that it could have been introduced much earlier. However, he did refuse, but he ended up accepting it towards the end of his life. And we felt that was at least helpful to him at the end. And he was passed away at home surrounded by his loved ones. Another case study was a 79-year-old male with ILD, combined emphysema and IPF. He had a decline in lung function and increasing oxygenation over the last year or so, which of course predicted his prognosis was very poor. He was also very hesitant to involve anybody else in his life, including palliative care, but he eventually did request it to us because he could see that his wife was just having a lot more difficulty taking care of him. So he really did it because of his wife, honestly. But after he was involved, we could see the symptoms improved a lot and he was much more relaxed and much more comfortable, and he also passed away at home. The last case study was a 78-year-old female. She had also IPF and COPD. She was on anti-fibrotic medication. She was actually pretty stable for a number of years, was on just a little bit of oxygen. She enjoyed traveling and camping all the time. That's what she lived for. But towards the end, we felt that we've seen that she had a lot of fatigue. Her energy was so low, and she was just exhausted all the time, very short of breath as well. We had ongoing goals of care conversations really from the beginning, when we had kind of met her in the beginning, but she actually asked us on her own one day. She just told us that it was time for her. And then she eventually had hospice and hospice care, and she finished up her last few months up north where she was surrounded by her friends and family. And we felt that was really what she wanted in life. Just some final thoughts to think about. IPF is, of course, an unpredictable and progressive life-limiting disease, or patients and their caregivers would benefit from early palliative care and those early conversations as well. Disease education, communication, symptom management, and supportive care are all an essential part of the team. And early initiation, integration of palliative care is essential to optimize their management while building up patient-provider relationships. And I think that's all. I do have some references here that I use, and then online resources, just to point out a few really good ones is, of course, the Pulmonary Fibrosis Foundation, that's pulmonaryfibrosis.org. And then the Get Palliative Care, I found was a really good one as well. And that's the end. Thank you for listening.
So much. All right, and taking us home is Amber now I can't say that anymore.
It's okay. It's okay.
It's the end of the day.
When you go from Smith to Martirosov, you know, it makes a lot of problems. My in-laws love to tease me that they should have made sure I could pronounce my last name before I actually married into the family, but. So I know it's Friday, it's like 3:37, and there's a lot of other things that you would probably rather do than listen to a pharmacist talk about what I'm about to talk to you about. But I think we here at Henry Ford have this really awesome program, and I know I'm biased. So if I was to disclose anything to you, my disclosure is that I'm very biased about our program. It's been a lot of blood, sweat, and tears on all of our part. But honestly, our program is really awesome, and I'm excited to show you what having a pharmacist on your team can actually do for not only you, your mental health and well-being, but also the improvement of your quality of care for your patients. I'm also gonna drop my mask as long as everybody's okay with that, because the more my mask touches my mouth, the more I'm gonna cough, and I don't wanna do that. So I'm gonna talk really quickly about what our role in this collaborative management program is that we've created. And then I'm actually going to walk you through the data that we did to analyze our first 6 months in the program and kind of demonstrate why that evaluation is so important. And then lastly, we'll talk about some of the common clinical scenarios where we as the pharmacy team really do make an impact during our multidisciplinary meetings. So a little bit of background just rather quickly, because most of you in the room are fellows and you don't know the same story the way that Dr. Thavaraja or Dr. Abu Saif do. Dr. Abu Saif was a fellow himself when I started. And when I was brought into the pulmonary clinic, at that time, our role was really to focus only on COPD management, because that was when COPD was added to the 30-day readmission penalty list. So that's where we started. And then over the years, we've really progressed from COPD to asthma. And then the COVID pandemic presented this amazing opportunity where you all were redeployed for pharmacy to say, hey, maybe we could step in and help with some of the management and things that are falling through the cracks with our patients that are on specialty drugs, such as the ILD anti-fibrotics. And in doing that, then in multiple conversations with the team, we were like, well, we should take this even further. So why did we take it further specifically with ILD and not really with maybe COPD or asthma or even PAH or sarcoidosis? And really what ultimately it started with was the relationship between myself and the providers, but also when we look at the drugs themselves, there's a lot of drug-drug interactions. Also, if you look at the actual maintenance rate of these medications, especially with the anti-fibrotics, almost 50% of patients will not stay on these medications because of the adverse effects of them. Okay. They also require constant monitoring, which is a heavy burden for our physician team. Furthermore, when you look specifically at patients that are getting ILD medications, there are significant delays in their ability to even get prescriptions. So we did a historical analysis looking at the ILD team's patients. And what we found is that there was anywhere between 45 days up to 6 months before a patient would actually start therapy, just due to insurance alone, due to the delays in prescription transmission and things like that. So because of that, now you're delaying treatment. That's a problem for your patient care. So that led us to building what we affectionately refer to as our ILD monitoring program. And why do we say it's monitoring? Well, I think it's really important to note we are not the diagnosticians. You guys just listened to a bunch of lectures about how to diagnose these things. I have an understanding. I could never do it in full practice, right? But when it comes to the drug therapy, I can initiate a patient on those drugs and I can monitor them very well. And so that's why we've kind of created this quote unquote monitoring program. So how did we do that? Well, the first thing we had to do was identify what our actual team looks like. And this really was at the leadership of Dr. Thavaraja and Dr. Abu Saif. So obviously the physicians and the nurse practitioner is very involved in it. Then we have the pharmacist, which is myself. We have Louise, who is our nurse coordinator. And then we previously had Tanja, hopefully will be replaced sooner than later as a social worker / case manager. And then, although she's not sitting in the room anymore, we have Beth, who is our administrative assistant, who saves all of us on a daily basis. In addition to this, I, in the pharmacy, have already what's called a collaborative practice agreement. This is a legal binding agreement with the Department of Pulmonary Medicine that allows me to act as a representative of the providers. So unlike other pharmacists that you might see on the inpatient side or pharmacists that you might see in like the lobby pharmacy, I have delegated authority to be able to prescribe based on whatever is listed in my collaborative practice agreement. So in order to improve what we were doing for ILD, we had to update that to reflect what I could be able to do in terms of not only ordering drug therapy, renewing drug therapy, discontinuing drug therapy, but also can I order labs? Can I monitor those labs and things like that? So we updated that so that we were following in a legal appropriate manner. And then we actually developed the program resources. And I can't say that I did this all on my own. I have a lot of residents and students that work with me. And so what we did is we created standardized drug tables that we use across every discipline so that the information our patients are getting is identical. We also built a shared patient database that specifically focuses in on monitoring. So Dr. Thavaraja kind of talked earlier about the database that Dr. Jennings created. We took a similar approach to that, but now this database is actually intuitive and allows us to be identified when a patient is due for labs, when they're due for a phone call from pharmacy to be able to say, hey, how are you actually doing on your therapy? And oh, are you actually still taking it? And it allows us to also be intuitive with when do the prior authorizations or manufacturer assistance programs need to be re-enrolled. So instead of reacting, we are ahead of the game and getting things addressed so that patients aren't having gaps in therapy. We also created a bunch of smart tech for our Epic notes. And then we formulated an actual script because although I'm the lead pharmacist, I oftentimes have residents and students. And so we wanted to make sure that the language that is used is the exact same across every person that's speaking. From there, we implemented our clinic workflow and kind of what we identified as the specific responsibilities for us. Obviously, in addition to what the providers are doing, we have to collect our own patient histories. And our patient histories really focus in on their drug therapy, which isn't just their prescribed drugs, but also their herbal products, their over-the-counter products. And a lot of times patients won't actually divulge all of their herbal products, and then we're left scrambling to figure out how that interacts later. We would also initiate modify medications, provide that in-depth patient education that supports what's already given during the provider visit. Then we order and evaluate those laboratory tests, obviously working very close with the providers as needed to adjust things as appropriate. Furthermore, we then assess adherence using a validated adherence scale, and we assess tolerability. And so instead of waiting for the patient to follow up in 3 months or waiting for the patient to call us, we are proactive and we call them every 2 weeks on a schedule to make sure that they're not having the nasty side effects that are often occurring. And then if they are, we have complete treatment regimens for how we can try to mitigate some of those side effects. So how does that work? Providers see the patients in clinic. They may take them to multidisciplinary rounds, which they've already kind of demonstrated for you earlier today. And then from there, they determine the therapeutic plan. Then we kind of come together as a team, and during those meetings, they will say, hey, we want to start this patient on these medications. During that team meeting, we're doing a quick review just to see if there's anything glaring that might make us worry. So things that you've already heard mentioned before. Does the patient have a history of coronary artery disease? Have they had a recent stroke or MI? Those are things that are often caught by the providers, but we're just duplicating that to make sure that there isn't a problem there. Other things that we commonly catch are things like, is the patient on Prilosec? There's drug-drug interactions with some of the meds, so we need to make sure that if they are, we pick the right med for the patient. From there, the provider will tell the patient either in a visit or over the phone, this is the medication we want to start with you. And then at that point, the pharmacist will call you and follow up with you getting from there. So that's what we then affectionately refer to as our enrollment. We evaluate all the things, make sure everything's good to go, and then we call the patient and we review in detail all of the therapy. So what is the actual drug? What does it do to your body? What are the side effects that you might expect? How do we mitigate those side effects? Then what is the monitoring parameters? And then here's our team and all the ways that we can help you. At the end of that phone call, we ask the patient, do you want to start therapy? If they say yes, then we enroll them. If they say no, then we go back to the team and say, kind of, this is what the problem is. Here's the patient's concerns. I would say there are at least probably 1 out of every 10 or 11 patients that does have significant concerns with starting. In addition to that, though, we as the pharmacy team during the phone call may assess things that were like, something about this call doesn't feel right. And at that point, that's when we would take a step back and call the nurse coordinator or call the social worker / case manager and say, hey, can you just do a second gut check with us? Because I'm not sure that this patient could actually be able to handle this. And that allows us to then bring it back to the team and say, guys, we don't really feel comfortable with this patient. They may not actually be a good candidate for this kind of therapy based on this, this, and this. From there, we conduct what we call the initial visit. So we do not do this until the patient actually physically has drug in hand. This usually is about 2 weeks from the enrollment call. And what we do with them is we again review all the medication details. We confirm what their start date is going to be, which then sets the clock for lab monitoring. We provide them with a written action plan and we send that to them in their MyChart. And then we create the monitoring schedule so that they have it written on their calendar and it's also in our database so that we can call them. From there, we perform follow-ups every 2 weeks for the first 2 months of therapy, and then every 3 months thereafter every month for 3 months, and then we do 90 days thereafter. And really our follow-up includes a lot of things. We're looking to make sure that they did get their labs done. If they didn't, we're reminding them to get labs done. We're making sure that they're not having any of those adverse drug events. We're looking at their symptoms and seeing, are they actually complaining of any shortness of breath or fatigue? Are their oxygen requirements higher? We also will talk to them about access. Sometimes our patients will get letters in the mail about a month after they get drug therapy that says, oh, you have to pay this much money, but it's not actually what the letter says. And so we're kind of interpreting that for them. And then ultimately that medication adherence scale. So let's talk about what our impact has been. So we did a single center retrospective quasi-experimental study where we looked at adult patients that were diagnosed with ILD who were newly initiated on either an immunosuppressant, an anti-fibrotic, and were enrolled in the monitoring program. We included anybody that was obviously actively managed by one of our providers. And then the patients that were in our intervention group were those that were enrolled between July and December of 2020. And then we had a comparator group of patients who had usual care when the pharmacy services weren't existing from July to December of 2019. We didn't exclude any patients. There wasn't a reason to. Okay, so what was our primary endpoint? So we actually looked at the number of interventions and outreaches that were conducted by the pharmacist for these patients. And then secondary endpoints included, what are those interventions? What do the outreaches look like in terms of number, type, and then what were those interactions like? And then characterizing, were they lab monitoring, financial assistance? Lastly, we wanted to look at kind of the prescription capture, and I'll talk about that in just a minute, as well as our patient satisfaction with the program. Because if our program isn't making our patients happy, is it really worth it? So what we had is we had 28 patients that were in our comparator group and 48 patients that were enrolled over that 6-month period in our intervention group. You can see that in terms of baseline characteristics, pretty evenly matched, no really statistical differences. So here's our primary outcome. So we had about an average of 13.2 pharmacist touches in the post-pharmacist group with a total of 632 outreaches for the 48 patients. Over that, it ended up being 8 months, the way that the end of the time counted was. From there, when we looked at the total team, so physicians, pharmacist, social worker, nurse manager, nurse coordinator, excuse me, and Heather, what we found was that in the post group, there was 1,168 outreaches versus 397 outreaches. And that what's also important to note here is that the total number of appointments actually increased for the providers alone. So because of what we as the pharmacy team were helping with, it's not all responsible for it, but because of some of the things that we were taking off their plate, that allowed them to also open up more time for more appointments. Secondary outcomes, you can see we did several dose decreases, drug holidays. There was also some medication discontinuations, adverse drug events that we were dealing with, and then really reinforcing adherence or education in some of our patients that weren't following titration schedules well. Also to note is that we had 50% of our patients that were sent to the Henry Ford Specialty Pharmacy compared to 11% in the pre-comparator group. what we found was by sending these patients, we actually internally generated a revenue of about $256,000. So when you think about a pharmacist salary, we're about $120K a year. And we were able to demonstrate that over a 6-month period, we made the system about $250K, which is pretty impressive. Furthermore, we did a patient satisfaction survey. We were able to get 36 out of the 48 patients to complete the survey. And you can see that the average N on a scale of 1 to 5, where 5 is extremely satisfied, we were about a 4 on all of them. So they enjoyed their clinical pharmacist. They understood their medications. They felt that the care that they gave them was important and unique. They were satisfied not only with the care from the pharmacist, but also from their ILD provider. And then, we had some really nice comments about how they felt like this program is valuable and really does add to their care. So really, when we look at the study itself, obviously there were some holes in the Swiss cheese model that we needed to adjust and evaluate, which we've done. But what we were able to demonstrate is really that using a pharmacist in collaboration with the other providers allows us to really improve outreaches to patients, ensuring that they're on medication therapy, and then really helping to free up the providers to be able to do other things. So when we look at our program as of today, we have about 200 patients that are on drug therapy and about 270 patients total that we've enrolled that have been on drug therapy. We have about 70 patients that have either expired or that had drug discontinuation or drug switches. It doesn't mean that they're not on drug, but they may have been switched from an anti-fibrotic, or that's not a good example. They may have been switched from like MMF and now they're on rituximab. We don't currently have rituximab in our database. And so because of that, they're off therapy that the pharmacy is managing, but they're still technically on therapy. We've also been able to improve substantially our workflows as well as the communication between our entire team and who's responsible for what. And then really, because of some of the holes that we've been able to identify, one example is being our rituximab. We put in these active treatment plans for rituximab, and then we expect that the infusion center will take care of those. But what we've been able to demonstrate is that they're not actually taking care of them, and patients aren't getting their second or third doses of rituximab. So we're now building out the database to be able to make sure that those patients are getting therapy and there aren't delays in those therapies as well. Furthermore, we have if they give me one more thing to put on our research list, I'm just going to laugh, but our list grows every day for plans for further research. Our drug database really does allow us to dive into what our patients specifically are facing in terms of adverse drug effects, and then what are the things that are actually mitigating the problems that they're having. So just really quickly in summary, I'm going to go through 2 quick clinical scenarios where we bring something to the team and how we've addressed it. So I think the first one is our CellCept interactions. We know that CellCept interacts with all proton pump inhibitors. The suspected mechanism is that we impair MMF absorption and or hydrolysis when your gastric pH is higher. And so because of that, you're not absorbing as much of it. And when we see in the clinical studies, there's actually a decrease in Cmax by up to 60%. So what we as a kind of clinical team decided is, when you look at the risk, it's recommended monitoring therapy and response. And if your patient has a treatment failure, then you switch them. But we've seen so much treatment failure that if we have a patient that is on a PPI that we can't really get them off that PPI, then our team takes over and tries really hard to get the patient on Myfortic. And that oftentimes requires a lot of fighting with the insurance, but we've been very successful in being able to get those patients on Myfortic brand or the Myfortic generic, which allows them to not have to stop their PPI therapy and still have great response to the Myfortic or CellCept. So you can see that those that are currently on CellCept, like I said, we monitor for close worsening. If they worsen, then we as a team discuss and switch them. If the patient is being newly initiated on it and we can't stop the PPI, then we would just start the Myfortic. So I think another important thing to think about is some of the risks that we see with the anti-fibrotics. So we know that anti-fibrotics elevate LFTs. When we look at nintedanib, it's about a 13% likelihood of elevating those LFTs. Pirfenidone is a little bit less at only 3.7, but we still can see those elevations. This is worsened when you have a patient that also takes agents that increase liver enzymes or are using or consuming substances that could worsen liver enzymes. And so when you excuse me, when you look at the package insert, there's absolute contraindications. So patients that are drinking should never take these agents, but also if you have patients who consume large amounts of Tylenol or who have history of hepatitis or liver cirrhosis, really you shouldn't use these in those patients. And you really want to make sure that you're counseling your patients that if they are using Tylenol, that they're using well below the recommended max of 3,000 a day. So one of the things that has become a discussion point for our team is that there are actually a lot of herbal products that can affect liver enzymes. So things like vitamin A, aloe vera, green tea extract, turmeric, and kava. The problem is that when you look at some of these herbal agents, these are known as either anti-inflammatories or antioxidants. So your patients want to take these because they're desperate to do anything that's going to reduce the inflammation in their body. But in doing so, it puts them at risk for liver toxicity. So we've actually noticed several patients that have had increased LFTs, and it's not right after starting therapy. They've been on therapy for 3 to 6 months. Their LFTs are completely stable. And then all of a sudden we start seeing this tick and their LFTs are getting, okay, maybe they're only like 2 times the upper limit of normal. And then all of a sudden they're 3 times the upper limit of normal. And when we have done like kind of a retrospective analysis of what's going on, the patients then say, oh, well, I saw my, herbologist and they told me to start this new product. And then we look at the product and it's got green tea extract, or it's got, turmeric in it. And as such, now we know that there's an interaction that's going on that's worsening. So what we as the pharmacy have done is updated our protocol. So now we have a very in-depth discussion with our patients about what prescription and non-prescription therapies they're taking, but also really reinforcing that, there's toxicity risks with these drugs. And that was very terrifying. Does that mean that we're...
The phone is there.
Yeah,
Hello?
Hang up that wall. Hi, you called into a lecture.
That's like if anybody's following the Johnny Depp trial, that's like the Amber Alert that went off in court this morning. If anybody was aware, just we're gonna roll with that punch. Okay. So anyways, by updating our protocols, we are now making sure our patients understand, hey, if you're gonna start a product, you need to call us beforehand, even if it was recommended by your provider, because just because they're recommending it doesn't mean that we do. And we've had this kind of discussion in terms of, even with like our CellCept or MMF, there's a high incidence of diarrhea with those. And in this COVID pandemic, everybody wants to take vitamin C, but very high doses of vitamin C can cause diarrhea. And now we have patients that are getting diarrhea that are on MMF. And is it the MMF or is it their vitamin C doses, right? So there's all of these things. And that's kind of what we as the pharmacy team are really able to investigate, dive into. And that takes the burden off of the providers in responding to those things so that they can be freed up to do the more acute care things that are required. So that was a lot. I tried to go as fast as I possibly could for you guys, but I'll open it up to any questions. If not, I'll turn it back over to Dr. Thavaraja.
all right. I just want to thank everyone again for attending either in person or virtually. Hopefully you got to see what we love about our team is that we have a team that we work with and have a lot of folks who bring wonderful things to the table. So again, I think you will look over and see if there's anything left in the chat here as we close.
Before we close, actually, if you guys can email me or Dr. Thavaraja any suggestions.
Absolutely.
Please,
Yeah.
this is our first annual ILD Symposium, will not be the last. So if there is anything, so some questions are not covered, so we're gonna try cover the next time, but please send us suggestions. Yes.
That was our suggestion to ourselves as well. And thank you. And he doesn't want me to, but thank you to Dr. Abusef, who really put this together. This is his passion project, and I thank him for his hard work on this. Thank you.